The recording will be posted on the Commission's webpage shortly after the meeting. TBW may also be streaming this meeting live and archiving it for additional viewing opportunities. For everyone's reference, today's agenda can be found under the first tab in the materials. Vicki Lowe, Chair of the Universal Healthcare Commission, will now call the meeting to order.
Hi, Scotchy, good afternoon. It is 2:04 and I'm going to call the meeting to order, the June 4th meeting of the Universal Healthcare Commission. I'd like to begin by giving a land acknowledgement. And I set my paper off to the side. So I'll just do it off the top of my head. Just a reminder that, you know, all of the land that we live on across the United States is indigenous land that was taken from our ancestors, and that we like to honor them and remember that they were stewards of the land. And when we think of healthcare, you know, we think of our communities. It's important to remember that the impacts of that loss of land have had on our people, and those impacts continue to play a part in the health disparities that we experience. And so that understanding comes into play when we are doing our work about thinking about universal healthcare and access to care for all of Washingtonians, including the Indigenous people. So thank you. And then really give a warm welcome to all our commissioners who are able to make it today and join us for this meeting. We appreciate the time that you put in being here. This is expanded 3-hour meetings is, I know, a lot, and we appreciate everybody continuing to join us in this work. So today we'll be going, I'll give you an overview of the agenda, doing the welcome now. Mandy will do the roll call. We need to improve the meeting summary from our last meeting of April 17th. We give time for public comments. And there'll be some updates from the Financial Technical Advisory Committee. So we have Pam McEwen here to do that as the liaison to that committee. We have the state agency report outs, so we can get an update on the important work that's happening at the agencies that support the universal healthcare work. We'll have a vote on the whole Washington on adopting the whole Washington draft report. Remember, we talked about it last time and we tabled it to give some more time to look through it. So today we'll be voting on it. We'll continue to look at solutions for administrative simplification, which will help pave the way for universal health care. Then we'll discuss our next steps. So I encourage each of you to chime in, ask questions, give comments, talk about, you know, what your thoughts are on these different topics. And as Mandy goes through to do roll call, as part of our getting to know each other better, the question this time is, what is your favorite time of day? Sunrise, daylight, twilight, or night? And please share why you picked that. So thank you again for being here, and I'll turn it back over to Mandy for roll call.
Thank you, Vicki. Good afternoon, Commission members. I will call members by their first name in the order listed on the agenda, which is alphabetical order. When I call on you, please unmute your microphone and let us know when you're here and what is your favorite time of the day, sunrise, daylight, twilight, or night, and please share why you picked that time of the day. Chair Vicki?
Present. And, you know, I like different parts of the day depending on my mood, but I would say my favorite is sunrise. I like the quiet time in the morning and get a cup of coffee and really kind of ground myself and think about all the things I'm grateful for and what I want to do with my day. Thank you.
Senator Ann? Senator Ann? Felicia?
Here, and let's see. I like the twilight. I think it looks beautiful.
Thank you. Charles?
Yeah, can you hear me okay?
Yes.
Okay, yeah, sunrise as well for me. Just the brightness of the morning and looking forward to a new day and the hopes that come with a new day. And yeah, just glad to be at the meeting today.
Thank you. Dave?
Hi, everyone. Dave Eisminger here on behalf of the Healthcare Authority. I'm going to break the mold and say nighttime for the same reasons that Chair Vicky said, minus the coffee. I like the quiet time. That's my time that I get to decompress about the day. So it's kind of like the exact inverse of what Chair Vicky said. But it feels like it's my time. I know that I'm not going to get phone calls. It gets this kind of like eerie quiet out in the world. And I just like knowing like that's my time to do what I want with.
Thank you, Dave. Senator Emily? Senator Emily? Estelle? Estelle? Jane?
Good afternoon. Definitely a morning person. Probably sunrise because that's when I'm working out every day and feeding my addiction to exercise. So that's me.
Thank you, Jane. Joan?
Hi all, Joan from the Health Benefit Exchange. I am Team Sunset. Mostly because they are beautiful. I like Team Sunset over a beach, preferably. Good to see everyone.
Thank you, Joan. Representative Joe?
I would have to say daylight because I like to be able to see and everything in its full color spectrum without shadows and stuff. So I would say daylight.
Thank you. Representative Marcus?
Well, I better stay on brand. I'm present. And also, since I brought forward the daylight saving bill, we need to hashtag ditch the switch and keep it lighter later in the summer and all those other things. Actually, my favorite time is probably 5:30ish in this late spring and summer because I'm likely helping coach or coaching on the soccer field. And I love it when these summer nights and late spring nights. So.
Thank you. Mohammed? Mohammed? And Mohammed did let me know that he's not feeling very well today and might not be able to attend. Nicole?
I would say that I'm gonna go with nighttime just because it's a lovely time to take the dog for a walk. And same reasons as Dave, less phone calls.
Thank you, Nicole. Omar? Omar? And Stella? Stella? Thank you, everyone. I'll turn it back to Chair Lowe, who will facilitate review of the meeting summary and public comments.
Right, thank you. Thanks, everyone, for playing along with the questions too. So if you turn to the second tab in your book, you can find the notes from the recording or from the last meeting. There's also a recording on our website, on the Healthcare Authority's website, on our page on their website. So is there any discussion about the minutes or the notes and comments? And if not, I would entertain a motion.
So moved.
Right. We've got a motion and a second to accept the notes. Any further conversation? All right, all those in favor of approving these notes, say aye. Oh, hold up your hand. Aye.
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 Any opposed? All right. The notes are approved and we will turn to public comments. So public comments that have been received since the last meeting can be found under the third tab in your book. And we will open up the floor to any public comments today. We allow individuals to sign up to provide public comment before the meeting, and we will start with those who have signed up to provide comments. If you have not signed up and would like to provide public comments, please raise your hand. Mandy will call on you after we hear from the individuals who have signed up. When you're called upon, please state your name and your affiliation, if any, before speaking. Please do not raise your hand more than once. This will help ensure that everyone has a chance to speak. You're also welcome to provide comments in writing to us if you don't get a chance to speak. You can email your comments at any time. Today, we're going to give 90 seconds per person who needs to speak, and we may have to reduce that if we start to run out of time. We will be displaying a timer on the screen. When the timer stops, please wrap up your comments. We encourage public comments to be focused on the materials and topics being discussed today. If we run out of time, we would really like you to send in your comments in writing. Mandy, would you please start with the names of the individuals who signed up for comments?
Yes, thank you. Chris Curry. Just moving.
My comment was submitted in writing.
Thank you, Chris. We did receive that, and that is in the packet. I know that you sometimes have technical trouble, so I appreciate that. Thank you, Chris. John
Was
Did you hear me, Chris?
No.
Oh, we did receive your comments, and you probably saw that it was in the packet. I saw that you signed up for public comments too. Did you have something more that you wanted to add?
I didn't sign up for public comment. I submitted it in writing.
Okay.
So it didn't appear in advance because nobody's had time to read it yet. I think the public comment system is a joke because nobody has the opportunity to respond. And we have no opportunity to discuss our concerns with members of the commission. It's just a perfunctory exercise to satisfy the law. And I'm really disgusted with this entire process.
Thank you, Chris. John Godfrey.
Good afternoon, commissioners. Can you hear me?
Yes.
My name is John Godfrey, and I'm the program manager for Washington Community Action Network. I'm speaking today in support of the
Lost our connection with John. Have a moment to come back.
Start from the beginning.
John, can you hear?
Yes, I can hear you.
Okay, would you be able to speak up? I can't hear you on our end very well.
Can you hear me now?
Yes.
Fantastic. All right.
Okay, thank you.
Thank
Would
you,
you be able to
Commissioner.
start over?
Yes, I'll start over.
Okay, thank you.
Thank you for bearing with me, commissioners. My name is John Godfrey, and I'm the program manager for Washington Community Action Network. I'm speaking today in support of the commission's consideration of administrative simplification, which with sustained effort can achieve savings for patients. This year, the commission has seen various presentations on this topic, which have yielded many potential areas for increased efficiency. In particular, our membership is excited about accelerating the clinical integration of behavioral and physical health. As stigma erodes and prices soar, we are hearing increasingly from the community about the inaccessibility of behavioral health care. We also support increased efficiencies in pre-service and standardizing prior auth as intended by the legislature when it passed HB 1357. So we are excited to see further work in that space. All of this being said, I would be remiss to neglect the elephant in the room. Ultimately, administrative simplification will not be enough without substantial structural changes to the system that causes these administrative nightmares in the first place. The fragmentation of a system with so many payers will always be too complex for regulators to fully address, let alone patients to understand. As long as there remains a dizzying multitude of coverage plans with differential reimbursement rates in a fragmented system, care will always remain expensive and inequality will be the order of the day. Universal coverage is not enough. Care must be low cost and high quality to be truly accessible, and the only way we can get there is through a single payer model. Thank you.
Thank you. Raleigh Watts.
Yeah, hi everyone. Hey, I'd really like to comment on Representative Rochelli's daylight savings time proposal, but we'll say that for a different meeting. I'm all in favor of that. I want to begin by just thanking everyone on the commission for your service. There are so many of us in Washington State, citizens who know that universal healthcare is the right future for Washington State, and we really care deeply about your work. So I want to thank you, and particularly our elected officials. My comment today is that I am not able to make a comment. The meeting packet was posted for citizen review literally minutes ago. I don't know when members of the commission received your packets, but we did not have access on the public website until literally just before this meeting. So as a citizen who cares about your work, this is not okay. I want to ask the commission today to set a standard or a best practice for when you expect your staff to make meeting materials available, for example, 3 days or 5 days or 1 week before the meeting, so that citizens like me can have a chance to review the packet. Healthcare Authority this year in its budget in 1 year has $341,000 in staffing support to support your work, so we should be able to get the meeting packets out on time. You might not be aware that representatives from Washington Can, from Healthcare for All, Healthcare Human Right, and Whole Washington, we all meet together once or twice a month related specifically to your work to track the progress, to nudge, to encourage, sometimes to prod, sometimes to support, and sometimes to critique the commission. We really need the packets in advance. Thank you.
Marcia Stegman.
Thank you. And I would just like to say thank you, Raleigh, for bringing those concerns up to the attention of everybody here at this meeting. And I would like to address the actual Whole Washington report. I've seen it. It doesn't look that much different from the report we saw several months ago. And so I'm wondering if has there been robust discussion? I haven't seen a whole lot of definitive action recommendations from this group or from the FTAC. A lot of asking questions. Oh, we should explore that further. We'll do that. And that's a transition. That's further. That's a gray area for the Whole Washington critique of their bill. I would like to see in this report something that is more a direct directive for action. I would like to see, hopefully you can put some specific recommendations and action steps. And this goes for the 2025 or for the November report to the legislature. Please have some action items, something you recommend that the legislature work on in the year 2025. We really need to move forward on this. It seems like we have the same benefits and benefits design and administrative simplification topic month after month and without a clear recommendation. So just again, thank you for your work. I do appreciate it. It is a lot of time that we all spend in these meetings, but it's going to be worth it if we can come up with a unified system for our healthcare in Washington. Thank you.
Thank you. I show Catherine Lewandowski signed up. Catherine, do you happen to be signed in as Whole Washington? Like, quick moment, Catherine. Hoping that's you.
Yes, it is me. Unfortunately, I can't change the name until you bring me on, so I'm not even gonna take the time right now. If that's okay.
That's okay.
Okay, would you like me to speak?
Yeah, go ahead. Thank you.
Okay, all right. Hello, Catherine Lewandowski, Vice Chair of Whole Washington. We are in the middle of our town halls, traveling around the state to speak to people directly, hear their healthcare stories, and share with them how we believe the Washington Health Trust can fix their problems. It's been stressful, tiring, but also very enlightening. We also have been doing phone banking to promote these town halls, and last week I helped with that for the first time. On my very first call, rather than getting a voicemail, I actually had a volunteer answer. She's a provider, works in a clinic in Seattle, and is a supporter and donor to Whole Washington. I'd like to share with you the gist of a long conversation, so I'll trim it down. She said, you know, I like you guys, but I got to be honest, it's never going to work. Right now, I hate my country. I hate our healthcare system. I detest the ACA. I'm sick of dealing with insurance companies, and having town halls won't help. Collecting signatures won't do it. It's a waste of time. It'll never get on the ballot. If it does, there's no way it'll pass. Our country is owned by the billionaires, and they will never let anything like this happen. The only thing that will make any difference is direct action. We need to stop everything, to obstruct everything. We need to shut this country down. That is the only way we can make a difference. I tried very hard to listen, to redirect her into what we were trying to do, to encourage her to come to a volunteer meeting. But in the end, I could really give her no evidence that she is not wrong. So I ask you again, when are the positions on this commission going to be filled with people who could care about fixing this corrupt system? We haven't had a citizens rep in more than a year. Thank you, Nicole, for showing up. We have never had a full cohort of elected to attend a meeting. They arrive late, leave early. Why are they on it? If I had that sort of work ethic during my career as a nurse, I would have been fired. I have never been fired. You all know what needs to be done to truly fix the system and deliver to our people a healthcare system that they can be proud of. So can we please get to work now? Thank you.
Thank you. I have Pam Kettner.
Thank you, Commissioners. Thank you, Catherine. I'm giving this talk with permission from my son. 2 years ago, my son had an unfortunate experience in a hospital here in Washington State. He was suffering from a severe mental breakdown and talking about suicide. He realized he needed to go seek inpatient facility immediately, but he could not find one quickly. So he went to the hospital where he thought he had read they would have one. No one there said they had an inpatient facility. So instead of getting a referral to that, they did invite him in to get some care. They gave him a dose of a ketamine treatment, and initially it was the wrong dose, but they did adjust it, and he stayed in the cold room for nearly 6 hours. Eventually, 2 social workers came in and said, here are some local inpatient facilities. When my son tried to get to them, they decided that his ER admission issues and gave them evidence that he was a danger to himself and required continuous supervision. This, due to the hospital's initial mismanagement, he was unable to attain the necessary care he deserved. So he had to turn to alternative therapies. Alternative therapies are very expensive. This costs $3,500 for 6 doses of ketamine. If you have ever had a family member talk about suicide, it never leaves your mind or leaves your heart. Please work harder at getting universal health care in our state. It's the right thing to do for all of us, and we need it now. Thank you.
And that is everyone I have for public comments, though, although I would like to take the opportunity to Vicky just apologize for the packets. We are extremely short-staffed. Right now, Angela has taken another position, and so it's just myself trying to fill in on this side right now. So I apologize for the delay in getting out the packets, but we are doing the best we can right now.
Thank you, Mandy. And no one has raised their hand to give other comments?
No.
Yes. And so thank you for those comments. I mean, we do hear them, and, you know, we do understand the sense of urgency, but also the work that's ahead of us. So thank you. Next on the agenda, we have Pam McEwen, who's going to give us an update from the FTAC meeting last month. Pam?
Good afternoon, everyone. Thank you very much for being here. Thank you for the comments. I did get my materials and was able to look at the comments ahead of time, so I did see those. So my report from the last meeting is that we started out with a report from what you all have been doing and kind of a refresh on our work plan and our work streams. We spent some time looking at, going over our understanding of where the Universal Healthcare Commission was in terms of looking at benefit designing in comparisons, and the decision to look at the exchange silver plans, particularly the essential health benefits and Cascade Care Medicaid, as well as PEB and SEB, especially looking at the extra benefits that are included in Medicaid, and then reviewing cost sharing considerations and options, particularly your decision to determine benefit design prior to cost sharing. David DeGiuseppe presented a buildup and cost analysis for a model health benefit plan. This is to kind of help ground us in how we would cost out this very, very complicated thing we're trying to do. This looks at including populations, benefit, expected utilization, administrative costs, and provider payments. He then introduced variables such as covering all the uninsured, looking at variations in cost sharing and introductions of cost saving measures. So it was really enlightening and really helpful for the committee. And this is, David is, what he does kind of the economic analysis for community health plans. So this is his day job. So it was really helpful for him to share his expertise with us in this way. We had a discussion after that, which included looking at other possibilities for benefit comparisons and discussing the criticality of cost-saving measures to keep a universal package as affordable as possible. We continued the conversation on cost sharing and looking at cost sharing both point of service and premium. And this is a significant part of benefit design and has a big impact on cost assumptions. One, note kind of parenthetically that I'd like to add, this was not part of FTAC's discussion, but actually looking at some of the public comment and listening to public comments kind of drove me to some of the websites of the groups that we've been hearing from most frequently. And there were comments there that a lot of countries that have universal systems do not have point of service cost sharing, which, when I dug into it, most do, almost all do. One of the things that's quite different, though, is there's often protections for people who are low income. So if we protect people in Medicaid because there's no cost sharing in Medicaid, but we don't do that in comparable systems. Like if you're in a private system and you're low income, you do have to pay the cost sharing. So my only reason for bringing this up is there are probably a lot of ways to think about point of service cost sharing in a universal system that are different than ways that we've looked at it in the very fragmented system we have now. And that'll be a commentary I'll be taking back to FTAC to discuss further as we get into cost sharing issues. After our discussion, we were able to hear from actuaries who listened to the presentation and were available to answer questions. I would say any takeaways from that conversation was that how complicated this kind of analysis is, how important assumptions are, and that it will probably help us all to be as specific as possible. We heard a lengthy presentation from the Healthcare Cost Transparency Board staff, kind of brought up to date on their work and their recommendations, and had very little time to discuss afterwards, but definitely everyone expressed the desire to continue to stay coordinated between all of these groups. So next steps are really coming back to all these topics at our next meeting. As always, FTAC will be eager to hear from you, any guidance, any discussion, any requests of work that you want us to be doing on your behalf. We'll be planning further discussion on benefit designs and comparisons, as well as cost-saving measures. So thank you. Any questions for me?
So Pam, this is Jane. Just a quick question, or maybe for Mandy. Are the recordings of the FTAC meetings available? Because I know I'd definitely like to listen to this one.
Yes.
Okay, great. Thanks.
I listened to it last night. It was really good.
Okay.
And I'm just wondering, is there any more direction that you feel the FTAC needs from us then? I know that we had a discussion about co-pays at the last cost sharing at the last meeting, and I know that, Pam, we've talked in between that, it's important for us to do our due diligence in looking at, I think it's no secret that I'm against cost sharing, right? So, but I also understand that to do things in the right way, it's important for us to look at the different options. So what does it look like to not have any cost sharing at all and have all of everything happen with the premium or the tax? I know, don't call it tax. And then what does it mean, what you were talking about, a system where there is cost sharing, but that's not really borne by the people lower income, which is kind of what we have now with the Medicaid program to an extent, and some of the QHPs and Cascade Care. But and then I guess the other level would be everybody has cost sharing, which to me is an equity issue when we have we look at cost sharing not as a percentage, but in a straight dollar amount. And that means that the people who with the lowest incomes are, more burdened with the payments. So, I mean, is it helpful to have us give direction on that?
I think it's helpful.
Already going that way.
No, I think it is helpful. I think, yeah, actually just the feedback we got from the last meeting was helpful in terms of stimulating thinking and questions about what direction to head. I mean, I think it's no secret that cost sharing, there are trade-offs with cost sharing. So no cost sharing means the overall plan is going to be more expensive. And there's always the trade-off between premium share and point of service cost sharing. So it's an important factor. There are some folks on FTAC who raise the issue of utilization. So that can have a big impact in terms of utilization of, for example, emergency rooms or certain drugs. So that's also another way to look at it. I think one of the things that might be helpful is to think in terms of options and looking at a potential of, mixing and matching options with benefit package and looking at overall costs and what the impact of costs and utilization might be. The key thing, I think, is affordability. And I think what we're hearing from the public and probably people are hearing in town halls is the burden of affordability from some of the plans that have very high cost sharing, very high deductibles, or very high point of service cost sharing, or people choose those plans and then find out later they can't afford them. And that's where a lot of recent medical debt has come from. So I think that needs to be an important factor in our discussions.
And I did notice, though, I was reading the notes, I think, where someone mentioned that, passing those costs to the insurance carriers, but I think we're forgetting that like 20 some years ago, the insurance carriers started passing those costs on to the people. So, yeah, I just wonder, does anybody else have any thoughts or comments for guidance to the FTAC? And on, I think they're on the right track where they're looking at the different cost sharing and really thinking about the impacts, not just on the payers, but on the people too, and trying to strike that balance so that we do have equity. I know you guys are here. I see your faces.
I can just nod vigorously with what you were saying, Vicky. So I think it's on the right track for the reasons you were just describing.
Okay. Anybody else? Okay. Do you need anything else from us, Pam? You guys are doing great. I can't always get to the meeting, but I enjoy being able to read the notes and watch the video.
Thanks, Vicky. I don't think right now I would expect after our next meeting where we kind of drill into some of these issues more, there may be some more specific things that we would want in terms of dialogue back and forth.
Okay. Thank you. Thank you so much.
Thanks.
All right, so next on the agenda, we have the updates, agency updates from commission members. I don't know did we have an order, Mandy, or just gonna whoever volunteers first?
I'd be happy.
Oops.
I'd be happy to. Charles, do you have any updates?
No major
Sorry,
updates
go ahead,
from, DOH.
Charles.
Can you hear me?
Yes.
Okay, yeah, I said no major updates from DOH at this time.
Okay, thank you. Dave?
Well, the Healthcare Authority has a variety of different things that relate to universal topics. I mean, we are in the midst of really promoting information about the healthcare. Sorry, we have so many things that have the letters H, T, and C in them that I'm going to mess it up. But I keep wanting to say HTCC, but that's HCCT, Health Cost Transparency Board, and helping promote information about costs in the system and how to try to equalize and put pressure that can only provide more relief within the overall healthcare system about some of the exorbitant costs within that system. That's just one example. We're also regularly looking at topics as we're preparing our decision packages for the next legislative session. I know that seems so far away, but it's very close. We always have an eye towards ways to try to eliminate barriers and equity and increase equity and access to care. We look at differences in trends between Medicaid and the PEB and SEB programs. It's one of the fortunate things about our agency having all of these programs together. We're in the rate development process right now for the PEB and SEB programs. And at the same time, we're, like I said, we keep an eye on how to keep and move things in a more aligned position between the two programs, recognizing that in the system that we're in today, one is an entitlement program and one is a talent acquisition program. At the same time, it's important for us to weed out differences and try to have things as aligned as possible, given our role as a state healthcare purchaser. So I just like to describe kind of like the way we do our work, even if I'm not giving you specific examples of the reports out. And Mandy, is there anything you think should be highlighted for HCA?
No, I think you did a very good job capturing that. The Prescription Drug Affordability Board will have some interesting work coming out towards the beginning of next year.
Agreed. So.
Thank you, Dave. Jane, I know that you're working on several items over there at the OIC. Do you have anything you'd like to share?
Sure, just quick in terms of upcoming reports that are on point, I think with the work that's going on, especially with the FTAC. By July 1, we're going to be releasing a maternity care cost sharing report that's going to include actuarial analysis of like 5 different models to either eliminate or reduce cost sharing for maternity care services. And it'll reach across commercial health plans as well as PEB and SEB. So I think it'll give some really concrete examples of, if we want to reduce cost sharing, what impact does it have on premiums? So Milliman's doing that work for us. If it would be of value to the commission, we're happy to have them present when that report comes out. And then August 1, our affordability report is going to be coming out, which is going to look at several different policy initiatives around affordability and what it would mean to implement those in Washington state. And then we've launched into rulemaking on the bills that passed the legislature this year. So ground ambulance balance billing, prior authorization from last year, the bill regulating pharmacy benefit managers, and then the various other bills that passed. And I will say, with respect to the prior authorization rule, we in the Healthcare Authority have launched our joint effort to deliver to the legislature by the end of this year, essentially a model it's a tiny little experiment in admin SIMP, so that we would present a model to the legislature around authorization for residential substance use disorder treatment that would say across the Medicaid MCOs, across the commercial health plans, Here's the information that's needed by the health insurers when they're authorizing care. Here's a form to use to do it. So the goal is to try to come up with finally an experiment with one common set of criteria for authorization for care that would apply, like Dave said, across HCA's programs as well as the health plans that we regulate. So that's it for us.
Hey, Jane. Omar, do you have anything to share?
Hi, good afternoon. Nothing to report out.
Thank you, Omar. Joan, do you have anything?
Yeah, sure. Thanks. Hi, everybody. Let's see, I'll group mine. I'll do my top three in terms of coverage expansions and access initiatives that might be of interest to committee members and folks listening in. We're sort of in the midst of a two-prong immigrant health coverage expansion initiative. The first piece happened in November so that people without a federally recognized immigration status could come onto the exchange and purchase a qualified health plan and qualified dental plan. We weren't sure, what the reach of that program was going to be, and we sort of saw the 100,000 estimated uninsured, undocumented people in the state. Almost a quarter of them, 24,000, came through Washington Health Plan Finder to look at their coverage options, which was pretty exciting. And several thousand signed up for health and dental coverage. So now we're just in the midst of sort of working with Healthcare Authority to support the expansion to the Medicaid population. So we are sending out a letter tomorrow to, 17 to 18,000 people who look eligible for that program and are not currently, submitted an application, but are not currently enrolled in any form of coverage. So there's a limited number of spots. So we'll be working with Healthcare Authority to support their outreach starting June 20th. People who are low income and undocumented will be able to enroll in the new Apple Health expansion. So helping, and they're going to be doing that through Washington Health Plan Finder. So helping and supporting them in that, in addition to people 65 plus coming through Washington Connection. So continued good work there. We're making some reporting and data available, and happy to bring that back at any point if it's of interest once we get on the other side of the Apple Health expansion. On the affordability front, we are working pretty closely over the interim with our federal delegation and others on the upcoming expiration of enhanced federal subsidies that have been helping sort of a historically high number of people on the individual market afford their coverage. There's more generous premium subsidies that were provided. They end at the end of 2025. So really looking to understand the impact here and with an eye toward the coming legislative session in particular. So that's sort of a piece that we're digging into. Also of interest, carriers just filed their rates for the 2025 plan year. We saw double-digit increases, about 11%, Jane, I think, increase this year. OIC puts out a good press release every year on the rate increases. So it was 11%. I think we still had around 10% last year and 10% the year before. So just looking to continue to leverage Cascade Care and these affordability efforts that Jane mentioned to try to look at how we can help make our plans as affordable as possible.
Joan, one thing I would add is those are the proposed rate increases. So at the actuaries, right, the actuaries at OIC are going through those proposed rate increases.
Yeah, and the last thing I'll say in rounding out my top three, that we have a statutorily directed auto enrollment study that looking at how we can further support and help transition people churning off of Medicaid onto qualified health plan coverage when if they're over income and turning off, how to help make sure they stay connected between the two programs. So we're starting that work. That report is due later this fall, but we're going to start engaging some colleagues at DSHS and some of the analysis we've done on the Medicaid unwind to further understand maybe some areas we could go to help connect people, particularly if there's low-cost coverage available to them, how we can help facilitate them over into a qualified health plan. So you'll be hearing more from us the exchange on that as we creep toward the fall as well.
Thank you. Rep. Riccelli?
Yeah, thank you. Joan, on the federal subsidy kind of wind down, I don't know if that's the best thing to go, but I'd be interested, we can take this offline, but I also think this group would be interested in seeing the impacts on plans or just understanding that a little bit better. I know we had some conversations during session, but as we lead into a conversation next year on affordability, I just helping to be able to really understand the impacts on that those the kind of stacked subsidies do have on people, I think is important. So I'd love to dig in on that a little bit more with you. And I don't know if there's other folks in this group. Because we did hear from public comments, some folks are acting like, what are some action plans? Well, there's action plans on the broader mission, but in the immediate term for affordability, I think this is one of the things that would be really important. So thank you.
And there was a Kaiser Foundation report, but did that break down into states? Because honestly, I just looked at the tribal stuff, so I apologize.
You know, what I can do, Vicki, is I can share, we've started some initial analysis here to help inform federal discussion and just our own kind of planning. So there was some public information we shared with our bipartisan board recently that I'm happy to provide if it's of interest to the committee. One top line is that actuaries are estimating 55,000 people will lose coverage without the continuation of the enhanced subsidies, which is, you know, when your whole market is 250,000 people, not a small amount.
Yeah, wow, okay. Well, thank you. Any other comments or questions on those updates?
This is Dave. You know, as I went earlier, as people were going, I thought of more things that would be relevant. And I actually really appreciate Joan and Jane bringing up different things that are collaborative between HCA and OIC and HBE. I should have thought about Apple Health expansion and described that a little bit. So I just want to thank Joan and Jane. But I was also thinking about how people may not be aware that as part of the operating budget, this past supplemental budget, that there is a legislative report that the Healthcare Authority is working on about the about different aspects of further or additional legislative potential consolidation of the PEB and SEB programs. It was actually that budget provision that is now being preliminarily worked on at HCA was spearheaded or initiated by some of the very stakeholders that come to the commission meetings and have heard us talk about and have heard me highlight, you know, I think that it's important that if, you know, an incremental step or a transition step could be getting some more public sector programs together into a singular program. And so there is a legislative report that is due at the end of the year on that topic. And we're anticipating that we're going to do some stakeholdering, some broad stakeholdering or high level stakeholdering on some of the topics that are in that report in the latter part of July or the beginning of August. So that's something that is also in the work that kind of directly relates to things that are commission related. So just wanted to add that in there.
Thank you, Dave. Anybody else? Anything else? Okay. Well, thank you. I think it's important that we hear these updates and understand the work that's going on, because it really, you know, we don't want to like build a whole separate system. We want to work together with what's already going on and like keep moving that work forward. So appreciate you guys being on this commission and then sharing that work so that we can understand. All right, so moving on, if you go to the 6th tab in your book, we have the whole Washington report, and we reviewed this at our last meeting, and we had our discussion, and then we needed to give time for feedback and comments and edits. So we haven't heard from anybody. Sorry, I know you're all busy, but hopefully you did have time to review it. And so we'd like to move towards voting to move this report forward. So I'm going to open the floor for discussion on that. If there's any comments before we move forward with taking a motion?
I just want to flag, we did hear from Representative Schmick, and your comments are added.
Oh, that's
Yep.
Yeah.
I'm sorry, Representative Schmidt, and Schmidt, and those were added to the appendix because they were more
Global.
general, global. Thank you. I'm sorry, I had COVID and my brain is still not working right. I'm better, but yeah, my brain's catching up. So is there a motion to adopt the report? And then it'll move forward to the legislature.
So moved.
We have a motion to move the report forward. Is there a second?
I second.
All right. So is there any further discussion? All right. All those in favor of sending this report to the legislature, say aye. Aye.
Aye.
Aye.
Is anyone opposed? All right, motion is approved. Thank you everyone for your time in reading that. And then next we'll move to Liz Arjun, who's going to give us a progress status on our work.
Hi, everyone. Good to see you. In the interest of trying to make sure that everybody is a little bit more in the loop and on the same page about where we're at overall, we did a little bit more work trying to kind of put a progress status report up, and then we'll continue to revisit each time. I know it's hard when we only meet every month and every 2 months to really kind of understand how the pieces are fitting and not fitting. And I think, you know, after hearing from the state agency updates, also realizing there's a lot of different pieces that we need to think about how to fold those in a little bit more specifically. I'm thinking, Dave, the one that you mentioned, we need to make sure we talk about that in Jane's OIC report. It's to maybe be a little bit more specific about how we call out those intersections, because I think they all are related. Just to sort of describe how we've tried to conceptualize this, we just want to break this down into there are 3 pieces of the work that the commission is tasked with, excuse me. Number 1 being the designing a universal healthcare system with a unified financing system. Second being focusing on interim solutions that address issues folks are facing now, and also that contribute or lay the groundwork for the universal system we're designing. And finally, the last piece, which was assigned in 2023, which is reviewing the Washington Health Trust proposal along the way and seeing how we can pull from that legislation and where there are some things that are synergistic or recommendations that we might want to fold in. And under each of these, you can kind of see over the course of 22, 23, and 24 what we've done in each of those buckets. And I'm going to go through those again very quickly. We can go to the next slide. So focusing on workstream 1, which is the universal design, we're over in the phase 1. And just to remind folks that that includes looking at benefits and services, provider reimbursement, participation, eligibility, financing, and cost containment. You know, during discussions last year, we talked about how all of those pieces could help inform phases 2 and 3, but really just focusing on answering the questions. And I think what Pam shared about the FTAX conversation is we're realizing how much of these different pieces in phase 1 interplay with one another in order to figure out the financing. So if we go to the next slide, you'll kind of see how we've structured this phase 1 conversation. Last year, we talked all about eligibility, what programs that are currently in place are going to be able to be folded in a little bit more simply into the universal system design. And what we have a little bit more work to do in terms of figuring out. And then this year we've spent time focusing on benefits and services. We plan to go to provider reimbursement and participation and cost containment. And all of that to roll up to figuring out how much is this whole thing going to cost, and then look at financing, which I know the whole Washington proposal has spent a lot of time thinking about. I think what we heard at the last FTAC meeting is that, and I know Jane had brought this up a couple of times, that it's really hard to talk about benefits and services apart from these other 3 pieces, in particular where there's a real focus in our state right now through the Healthcare Cost Transparency Board and the work the OIC is doing to really try to get our arms around why are things so expensive. So that's what you heard from Pam, and the conversations at FTAC are really kind of trying to go through all of those pieces as we look at the benefits and services and figure out okay, how can we actually, if we had all the benefits and services that we've envisioned, how do we minimize the costs for consumers and also figure out, lower the cost of trying to finance this program in the long run. So that's the update on work stream 1. If you want to go to the next slide, well, actually, no, I'll just say work stream 1, the progress that has been made. And I know it seems very slow, but just to sort of to describe the way that we're thinking about it, last year was really spent going through each of the types of the different programs we're assuming everyone is eligible. But we also realize that when we say they're eligible, some folks, it's much easier to bring them in to the universal system than others. And so over the course of the last year, the decisions that were made are that for folks who are enrolled in Medicaid, individual market plans, small group market plans, and the fully insured large group plans, including PEB and SEB, and the uninsured, those folks can be part of that core population in the sense that we can design benefits and services and cost sharing to really cross all those groups that look the same. For folks who aren't in those markets, and that we're talking about self-funded plans, the commission and Medicare, the commission did agree that we want to find a way to achieve parity for those folks. So as we're having the conversations about what the benefits and cost sharing, et cetera, and details look like for this top group, we're going to be looking along the way about how we can achieve parity, both in terms of affordability and benefits for those two populations. Is it a buy-in? Is it what kind of a recommendation could we make around self-insured employers to offer something similar or pay a tax that's not going to trigger some ERISA challenges? So again, agreement from the commission on that everybody should have the opportunity to get something the same. It's just going to look different about who gets the whole banana in the beginning and who gets to buy into or find another way to achieve parity. So that's the update on, and then we'll go to the next slide and we'll talk about, what's coming up. And again, we've given direction. Sorry, I just want to pause for a minute. We've given some direction around the packages, the benefit packages that we want FTAC to be looking at. And Pam described that earlier, the PEB, SEB, Uniform Medical Plan, Essential Health Benefits, Cascade Care, and Medical, Dental, and Vision, Medicaid, Dental, and Vision. And that has helped the FTAC to sort of hone in on that and provide some guidance to the actuaries. And I think the real focus now, as Pam shared, is that we're looking at how do we minimize enrollees out-of-pocket costs, both through cost sharing and just the ultimate cost of this system. Next slide, please. So workstream 2 is that interim or transitional solutions. And I think this is something that we heard a lot about, some of the updates during the state updates. And I think it's something that the commission should feel very proud of in terms of using its platform to really talk about some of these important policies that are now getting implemented. This group did make a recommendation to expand coverage for uncovered populations, including the undocumented folks that both the Health Benefits Exchange and the Medicaid agency, Apple Health expansion, that are now rolling out. So that is a really, really, really big accomplishment. And I know it's 20 years in the making. And it's important that the commission recognizes how important that is. Also, the commission made recommendations on around an integrated eligibility system. They made some recommendations around the Cascade Care Savings Program, which has brought down the cost of coverage for folks in the exchange. Also, the commission has endorsed cost growth targets that the Health Care Cost Transparency Board has put out, and then also made a recommendation about aligning public programs. And I think what Dave mentioned earlier around the PEB SEB report later this year will provide a nice kind of report on what that might look like. In terms of interim and transitional solutions, it took a while to come up with what the areas for focus in the future were going to be. And we spent a lot of 2023 interviewing commission members and going through different areas about where we thought we could get the most bang for the buck or what issues were being addressed elsewhere. And the two larger buckets that the commission settled on focusing on in 2024 are administrative simplification, and we've been spending our time on that the last couple of meetings. And then secondly, maximizing coverage in existing programs. And there were several pieces, several different ideas that folks brought forward. For example, the consolidating, expanding purchasing and increasing participation in the Medicare Savings Program, fully funding the Apple Health expansion, and doing some auto enrollment. So those are the pieces that that you all said last year we want to spend our time learning more about and come up with some very tangible recommendations to make to the legislature. Let me go to the next slide. Finally, on workstream 3, which is reviewing the Washington Health Trust bill, the folks from Whole Washington have been able to present or come and presented to the commission on the overall proposal. They came to the FTAC to talk about benefits and services and their cost assumptions. And as you all just voted on, there's been a draft report of some of the back and forth or comparison between that legislation and the work that we're doing. And so that has been done for now. And we anticipate that there will continue to be presentations about the Health Trust as the commission and the FTAC go deeper into the topics that we talked about in workstream 1. So we can go to the next slide. And that's our status report. I don't know if if there's any questions or comments about that. Okay. I'll turn it back to you, Vicki.
All right, thank you, Liz.
I think it's break
Again,
time.
one more opportunity for comments or questions. It's good to have the update and reminder of all the different things we're working on. Several balls in the air. Let's see, I guess because we've transitioned to longer meetings, we want to take an opportunity to offer a little break here. What time is it? Well, we're past our break time. Do you guys want to take a break, like a 5-minute break?
Yes, please, Vicki.
Okay.
Oh, we forget. Yeah, the in-person people, they can't
Oh,
get
I'm
up and go
sorry.
anywhere. They're stuck.
We're so used to Zoom live, so we'll come
Yes.
back at 3:11. All right,
All
go.
right. Thank you. Stop the video. Okay, sorry.
All right, are people starting to come back? 5 minutes goes by quickly. All right. So welcome back, everybody. Next, we'll have Liz back again to provide the summary, progress on the administrative simplification or admin sim, but looks like Charles has a question or comment first.
Yeah, thanks. Sorry, I just wanted to ask a question on the status updates in the last section. Specifically in relation to the challenges we have with figuring out a pathway for the self-funded and Medicare plan. So I know that's a gap and a challenge we have currently, but I guess just wanting more information on how that has been addressed, like with regards to the process for, because that's a major part of the market, right? So really, how do we, I know we don't have a solution today, but what's kind of the plan? So just awareness with regards to how we're going to approach that gap.
Yeah, thank you for raising that. I think at this point, and I don't know if Pam is still on or Mandy or Vicky want to comment. At this point, the approach has been to kind of hold on that until we have a sense of what the benefits and services and kind of the core package are going to look like, and look to ways on which we might achieve parity. So we haven't really scoped out a work plan to do that, but we know it's something that we have to circle up on once we kind of address these foundational issues here. Does that make sense, Charles?
Yes.
Yeah, because we just don't know what we're trying to achieve yet in terms of equaling it.
Yeah, makes sense.
But there were, I will say there were, the FTAC presentations, particularly on Medicare, were incredibly helpful in terms of understanding what some of the options might be. So I would encourage you to go back and look at those.
And Mandy put the link to where the meeting, the videos
Yeah.
of the FTAC recordings are, if it's helpful to go back and look at some of those. I did a presentation on the program that I ran at my tribe for almost 20 years, which was basically, we picked a level of benefits for our tribal members, and then we worked with whatever coverage they had, including Medicare. So for people at Medicare, we either bought them a supplemental or paid the 20% and bought them prescription drugs and just made their coverage equal. And without a federal solution, I mean, the FTAC's ideas were a little more intricate than what we did at my tribe, but just same ideas. How do we get them on parity and then still push for that federal change so that eventually they could come into the system?
Right. I also think there's a little bit of thinking too, that if we can prove a proof of concept here that this is going to work with the markets that we can control, it'll make it much more likely that the feds would give us some type of, to be not happened yet waiver. So anyway,
yes.
Yeah.
Thank you.
Yes. Thank you for raising that. All right. So just kind of going back to the conversation we had, we're drilling down on work stream 2, which is the transitional interim solutions conversation or focus. And we're continuing our conversation on administrative simplification. And I'm just going to do a brief recap as best as possible over the last 2 meetings about what we've heard and what we're focusing on today. Thanks. So let's go to the next slide. So in February, we heard from national experts about the savings that could be associated with addressing administrative simplification. We also heard from HCA's medical director about some of the efforts that they've been doing inside the agency to do this. In April, we heard from folks at One Healthport, who's been leading some of the work on administrative simplification here in the state, about what their experience has been in some areas of opportunity looking forward and lessons learned. And then today we have the opportunity to hear from providers and hopefully begin to focus on some recommendations from this commission. So we can go to the next slide just to recap what we've heard over the last couple months. hopefully, you know, for folks who were there or watched the video, we're back in February, we heard from 2 experts who recently put out a paper at Harvard and McKinsey focused on the potential cost savings associated with administrative simplification. There were a lot of, I think there were a lot of eyes that were opened and questions that people had and excitement around some of the ideas that they presented. And, you know, I think a couple of the important things that I just wanted to remind everyone were that what they tried to do that I think helps provide a nice framework is that this admin simp thing is a very big topic. And they really encouraged us to think about it in 5 functional focus areas, to just kind of wrap our brains around it and identify where we might want to focus our attention. So the financial transactions are one area, industry-specific functions, administrative clinical support functions, customer and patient services, and then things that are industry agnostic. The one that stuck out in my mind with this industry agnostic was that when they talked about having a barcode that anybody could use. So I think that it was really inspiring to a lot of folks to hear that there are some things that can be done. But I will say one of the takeaways was that a lot of these, you need to get all the players involved, and that it can't just be voluntary participation. If we go to the next slide, we heard from Chris Chen, the medical director at HCA, about some of the work that they've been doing to reduce admin burden over the last few years. They've been trying to do a lot more alignment and oversight across programs and contracts. I know Dave is living in the middle of this, I'm sure, with his PEB/SEB, and also then there's Medicaid, which HCA is responsible for, and that is a huge chunk of the market in the state. So they're trying to do as much as they can to do that. They staff the Performance Measures Coordinating Committee to align quality metrics. They have the Multi-Payer Collaborative for Primary Care Transformation. And they have worked on the interoperability rules for implementation with the focus on prior auth. And we heard from Jane, there's more work happening in that space. And then to the last point, participated in the work that One Healthport has been leading under OIC around admin simplification. And that just leads us to the next slide, which was our last meeting in April. We heard from One Healthport about all the work that they have been doing on admin simp over the years. And I think the key takeaway that we were left with were there were some areas that Rick identified that locally may be ripe for focus on admin simp, and including expert stakeholder review, pre-service, consumer engagement, performance measurement, focus on social determinants of health, and then behavioral health. And I just want to mention and sort of echo what Jane mentioned about the project that they're going to be launching on prior auth for inpatient behavioral health that hits on 2 of these. So lots of work is starting to happen. And so that's what we've heard about. And I think today we have the opportunity to hear from some panelists about what does this really look like for them, and what are some of the recommendations or some of the ideas that the commission might consider in how to address this, and how could we relieve some of the burden from them. So any comments or questions from any of those presentations, that are things that stuck with folks that you just want to remind people of as we move to the panel?
I guess one thing that I would note, especially with Rep. Riccelli and Rep. Schmick here, is one of the things that we've been pleased to see is the legislature in bills that they've been passing, trying to look across Medicaid, PEB/SEB, commercial health insurance. Probably the prior auth issue is sort of one of the really nice examples of that, but having the opportunity to have the legislature understand how important it is to try to have consistency across all of these programs is really of value.
Thank you, Jane. That actually just underscores the comment that I made a little bit earlier, that one of the other key takeaways, I think, from Rick's presentation was about you have to have all of the folks at the table, and voluntary isn't necessarily going to work on some of this. It's going to have to be required. in order to actually get the bang for the buck and make it work for providers and for consumers. So. Great.
I have a question.
Sure.
If you can show that there's true savings here, I can understand why there would be reluctance in wanting to make adequate changes and through the things that you're discussing. I'm not able to connect the dots there, because if you can see a way that you're going to be able to save money and a better consumer experience, who would resist and who would not want to do that?
That is a very good question. I'm going to kick it to your fellow commissioners to have some thoughts on that. I think it's a really good question.
So Rep. Schmick, I think oh my God, there's so many things to say about that. So what I can say is the following, that, for example, where you've got the big national carriers, right? Aetna, Cigna, United, they're developing policies, procedures, et cetera, that cross state lines. And I think their interest in part is to have some sort of consistency across the states that they operate in. So that might be one factor. I do think that the changes to systems are hard, right? Because it's sort of like, this is the way we've always done it. And getting, having discussions about that, and also just having both providers and carriers understand and be willing to make the investments that are needed to do those things. The perfect example is in House Bill 1357, the prior authorization API. We're working right now on the implementation of that system. It's a big system lift for the carriers, and the key to success of that, saving money, making it simpler, is the providers being able to modify their electronic health record systems so that they'll talk to each other, so that the carrier's prior auth system will talk to the provider's electronic health record. And so it's educating those providers about the value to them of making that investment, so that rather than faxing 10 or 20 pages to a carrier, all they have to do is ping the carrier, and the carrier is going to pull the information out of their electronic health record. It's just change, right? It's really hard, which doesn't mean it shouldn't be done. But that's
Just as
some of the experience.
and I appreciate that. Just to follow up for a second, anytime that there has to be IT changes cost money, whether it's the HCA or the carriers or anyone. I mean, this stuff just doesn't happen, and it is not cheap to do that, and someone has to pay for that. So I guess my comment is that I hope that there would be some collaboration among the carriers, HCA, as we move down this pathway, because there's been several comments made about, well, we're just going to force the carriers to do stuff. Well, I view that oftentimes where we're going to ask them to do it, and it's going to cost, and those costs are going to get passed on. And so even though there could be savings, to get to the savings, there has to be significant investment. So maybe it's a chicken or the egg argument, but just whether we ask the HCA to do this or we ask carriers to do it, IT time is expensive, and I'd like to hope that we would want to have a goal we get to the same place. I just know that stuff just doesn't happen.
And I think on that example, the legislature has said to the carriers, you need to implement this prior auth API. has not said the same thing to the providers, but how can the providers be brought into a collaborative effort with everybody sitting around the table together? And how can it be shown that it's a net positive for the providers to make those IT investments in terms of their ability to not spend a ton of back office time on prior auth, number one, and number two, be able to tell their patients, yep, we can get this done. It's not going to take a week to get it approved. But it's a lot of education.
Well, and Jane, you mentioned your little experiment that you all are doing.
Mhm.
I'm wondering to the extent that that is a kind of learning lab for some of the things that we're talking about here.
I
trying to-
think it is.
Yeah.
I think it is because using the prior auth API is you want to get the carrier's IT prior auth system to communicate directly with the provider's electronic health record. But that doesn't go to what information the carrier wants to pull from the record. And each carrier can ask for different information. But under Senate Bill 6228, with the authorization for for substance use disorder treatment, the idea there is all of the carriers are going to ask for the same clinical information using a consistent form so that you don't have the problem of, well, I need to give Premera this, I need to give Regents this, I need to give KP that. So it's like taking it up to the next level in terms of admin SIMP. And it's for a service that we all know is super challenging to access.
And I know that it's actually a really good thing to pivot now to our next topic because one of our panelists is actually an SUD provider and I think can probably speak to that. So I'm going to turn it back over to Vicky.
All right, thank you. Thank you for that question, Rep. Schmick. Next, we have a panel on administrative simplification or admin SIMP from those who are involved in the provision of healthcare. So the panelists are Diane Hong from Family Medicine, Jeb Shepard from Washington State Medical Association, Samuel Wilcoxon from Premera, and Steve Woolworth from Evergreen Treatment Services. And I think each of the panel members have prepared a short presentation. Looks like we're starting with Jeb Shepard. And then we'll move into some Q&A and panel discussion following their presentations. So I think are we beginning with Jeb?
That's fine. Speaking with Jeb, are you okay with that, Jeb?
Yeah, I'm great with that. Thank you.
All right, sounds
Okay.
good.
Yeah, thank you, Chair Lowe, and members of the commission and the Healthcare Authority staff for inviting us in to share our perspectives on this issue that impacts the cost of care and patient care. I'm glad that Pam noted earlier in the meeting that members of this commission have been meeting with the Healthcare Cost Transparency Board. I know that group has an interest in administrative burden, but they have decided to defer work on it in order to allow you all to work on it so that they can learn from you and perhaps incorporate it into some of their recommendations as well. So feeling a bit like we have two audiences today, but very, very grateful to be here. Next slide. Just a really quick overview of what the Washington State Medical Association is. I'm Jeb Shepard, Director of Policy at the Medical Association. We represent physicians and physician assistants in every specialty, practice, size, setting in every corner of the state. Next slide. I just wanted to start with sort of a humorous visual around this topic today. You'll see the house call, the office call, the 1-800 call, and the conference call. And it just really illustrates how over the decades, physicians feel like a lot of administrative requirements have come in between them and their patients. A recent study in the Annals of Internal Medicine discovered that during an office day, physicians spend just 27% of their total time on direct clinical FaceTime with patients and 49.2% of their time on EHR and desk work. A lot of that is clinical documentation requirements as set by various programs. The study found that on average, physicians spend 1 to 2 hours of personal time each night doing computer and clerical work. They have a name for it that's called pajama time when they're doing this work at home. These are stressors and they're contributing to record levels of physician burnout. So there's a human cost on providers as well. These types of burdens are leaving physicians struggling to find joy and meaning in their work, leading to increased risk of serious physical, psychological harm, threats to patient safety, and an increasing number of doctors leaving practice. Next slide, please. Administrative burden is the top issue among physicians. So we surveyed our members a couple years ago, and out of 30 issues, we asked our members to rank administrative burden was at the top, and prior authorization sort of rested on the top of those administrative concerns. Many practices report, and I'll show you some data later that confirms this, that they have to hire a full-time employee just to do certain functions like prior authorization. That comes with, when you're hiring an FTE, it comes with significant costs that need to be offset somewhere else, right? Typically through rate negotiations and things. Next slide, please. Measuring, you can't fix something unless you can measure it or improve it. And measuring administrative burden is notoriously difficult, but there have been some recent studies on this. This is a place and time study from 2018 to 2020. It's a pretty small sample size, but what I wanted to illustrate on this slide is it's a pretty unique problem to our healthcare system in the United States. It's been spoken to, I think, already about the fragmentation of our healthcare system, and that is borne out with more administrative burden, more cost to the system. Next slide, please. I'm going to try to fly through some of this background because it sounds like this group is pretty well grounded in administrative burden, but I'd be remiss to not mention that 25 to 31% of total healthcare spend in the United States goes towards administrative costs. I want to be very clear that not all administrative costs are bad. You have to administer these programs, right? And so there's going to be some level of administrative costs that makes sense. I think where we start to see concerns is when we get into wasteful administrative spending. And that's the area where we want to focus. I don't think anyone, it's one of the few areas of healthcare where everyone agrees that we shouldn't have wasteful spending, right? That's an area where we could improve patient care without spending more money, if we could get at that. Next slide, please. Just a quick note on administrators. Since the 1980s, 1990s, the managed care movement, we've seen a rapid acceleration in the need for administrators to keep our healthcare system functioning. This chart ends at 2015, but if you look ahead between 2021 and 2031, we are expecting 616,900 medical and health service managers, so over 500,000 FTEs to keep our healthcare system administered and functioning. Next slide, please. Again, you all seem very well versed in prior authorization, so I won't spend too much time on this slide, but it does cost physician practices a lot of money. So there are stakeholders who will note that prior authorization is needed to help reduce unnecessary care. There is truth to that. I think where we start to get concerned is when appropriate care starts being denied, and when the systems in place are unique to each individual payer. I really liked Rick Rubin's door slide from your last meeting where he had one door and he said if we all use the same door, we could all probably figure out that door and we could move freely in and out. But when you've got 100 doors to navigate, could get more difficult. And then again, there's the data, 40% of practices have staff who work exclusively on prior authorization. That's a cost to our healthcare system. Next slide, please. The legislature directed the insurance commissioner to do an annual report. We're looking at data from 2021. I didn't have time to update this slide, but the trend largely holds. The insurance commissioner has put together this report around prior authorization and looking at a certain set of codes. The majority of these codes are approved 100% of the time, yet physicians and patients are jumping through administrative hoops like denials and appeals to get these approved ultimately, almost 100% of the time. And so it does beg the question, why are we doing this? Why are we putting barriers to patient care? That's deemed appropriate at the end of all this administrative red tape. Next slide, please. We're very thankful to the legislature for taking another crack at this. Thankful to Rep. Simmons. I believe Rep. Schmick was a co-sponsor of this legislation as well. We're very excited about it. Shorten and standardize the timeline and the process again, so that you have some continuity among the various payers. Increase transparency requirements so that everyone's on the same page about how to operate one of these programs. One thing we're really excited about, because we think it's going to improve the prior auth experience for everyone, is integrating the prior authorization process into the electronic health record that will build it into the workflow of the clinician and speed these processes up. I do want to mention the ERISA problem, and I believe Rick mentioned this last week, and it's been a topic of conversation, maybe in a little different context of this group, but whatever the state does, it largely cannot touch these ERISA plans. So the really large, some of the really large healthcare carriers in this state are actually not required to comply with a lot of these rules and regs that we pass, unfortunately. So that's another big area of concern, is we just can't touch certain elements to make these types of improvements. Next page, or next slide, please. This is just a slide that we put together to illustrate how many different entities regulate healthcare at the state and federal level. We have the legislature, the Department of Health, Healthcare Authority, Labor and Industries, Office of the Insurance Commissioner, just at the state level alone. And then at the federal level, there's Congress, Medicare, Medicaid, OIG, and on and on. Thousands of rules and laws are passed related to healthcare. All of those must be implemented. And as noted earlier by Rep. Schmick, those do have a cost, right? And so, next slide, please. The problem, in addition, with administrative burden, in addition to putting barriers up to appropriate patient care, is it increased costs on practices. We are seeing practices close down, small ones, outpatient practices. A lower cost setting is struggling, have been for a decade and a half. And we continue to see a trend of outpatient practices who are sort of struggling under the weight of administrative burden without a requisite reimbursement to hire staff, et cetera, to jump through all these hoops. We see a lot of consolidation. So the last thing a physician wants to do is to see their practice go away completely and not be there for the community anymore. And so often their only option is to sell or to merge with a healthcare system. That burns them out. It makes them leave the workforce. The one takeaway that I would really like for you all to have, and for the Healthcare Cost Transparency Board to understand as well, is that we can reduce costs in a lot of ways. We can put rate caps in, we can prevent the ability for groups and health systems to merge. But if we put those types of strategies in place without addressing the system problems of administrative burden, it's going to have a devastating effect on physicians, patients, and practices in terms of their viability. Next slide, please. And I would urge you to read May 20 Seattle Times. We had an opinion piece published about the challenges that the outpatient community is currently experiencing around payments that don't reimburse for the cost of delivering care, and that includes administration. That's the front door to Seattle OBGYN, which closed its doors earlier this year, citing low reimbursement and challenges with compliance and administration. So with that, I will hand it over to the other. Oh, I'm sorry. Can you jump ahead one more slide and then I'll wrap it up. Wanted to come with some solutions to offer. In terms of reimbursement rates like Medicaid, we've brought forward proposals to increase Medicaid rates that would more accurately account for the cost of delivering care, including the administrative elements of delivering care, eliminate where possible or drastically improve standardized administrative processes like prior authorization, credentialing, clinical measures. The legislature has done amazing work in this area over the years. And then policymakers should view well-intended initiatives through the lens of access to care for patients due to potential adverse impacts on small, rural, and/or underserved practices. We're not all out to get one another in healthcare, but I think I think everything is well-intended, but we need to think through the unintended consequences before putting things in place. And so, I would urge policymakers to keep that in mind as they bring their solutions forward. And now I'll hand it off, Mandy. Thank you.
Thank you.
Would you? Thank you. Go ahead, Mandy, who's next? Sorry.
I was gonna say, Diana, would you like to go next?
Hello. I lost audio for a minute there as I was joining.
You're good now. We can hear you.
Yes.
So I have no formal presentation, but I wanted to kind of introduce myself and give you my perspective as a family physician. My name's Diana Huang. I work at Swedish Downtown Primary Care, which has an office a couple blocks away from Seattle City Hall. So I see a broad diversity of patients, lots of patients on Medicaid who may have recently come to the city and are working there, might be commuting from far, but also federal employees and people who work at our big IT companies, Microsoft, Amazon, and also Boeing that have kind of strong private insurance. So I get to see lots of different aspects of care and different, I guess, challenges as far as administrative burden coming from these different kinds of payers. Just to give you a little bit of context, it's my first time meeting you guys. It seems like you're all very well informed, but just some basic things from my perspective. As a physician in one of the kind of major health systems, most of us are paid based on our FTE, which is based on how much time we're spending with patients. And so for a bit of context, whenever the University of Washington internal medicine physicians are graduating from residency, they are recommended to not take any more than a 0.8 FTE because more than 0.8 FTE is not considered kind of sustainable. Because while that may mean, depending on the system, 36 hours of patient-facing time, 38 hours of patient-facing time, you know that you're probably going to do another 20% on top of that of administrative work. And so actually you're working much, much more than that.
Could I jump in just for a sec? Could you explain that one more time a little bit more so that we're very clear about what you're talking about, the 80%, please, because I've not heard that before. And so thank you.
Yeah, sure. So clinicians, whether they're physicians or PAs or nurse practitioners, they're usually paid on a contract based on FTE. So they're kind of what counts as a full-time position. And so usually that is based on patient-facing time. So if I worked a 1.0 FTE, that would be kind of with full benefits and everything, in my organization, that's 36 hours that are scheduled with patients. And then of course, you're like, you have to do the administrative work that is associated with that. And that stuff is not compensated. It's just kind of part of the time. And so what I mentioned as far as the UW graduates being told to not take more than a 0.8 FTE, it was felt that kind of the administrative work related to that is not sustainable within kind of a regular lifestyle and having time for family. Because probably a 0.8 FTE, even though that's probably around 32-ish patient-facing hours in a week, you'd be doing an extra 20 to 30 hours outside of that. I'd say starting off probably 20 to 30 hours outside of that. And then as you get more efficient, potentially like 10 to 20 hours outside of that, but it's a lot of time that you're doing outside of the patient-facing time. So whenever I started in my career, I started as a 1.0 full-time, but I had a child coming back. I know that I used to do 1.0 at FTE, would spend my weekends doing administrative work. And now that I need to take care of my child, I reduced to a 0.8 FTE, which means about 31 hours of patient-facing time during the work week. And then I'm able to, like, I take Thursdays off, but I actually am doing administrative work basically on Thursdays to try to take care of all my patients' needs. So I think that is kind of the burden of this work. And so I really appreciate that you guys are giving time to this today and thinking about ways to help simplify things, because it really does matter. It's something that causes a lot of physicians and other clinicians to leave practice because the administrative work is really not rewarding. I mean, it's not financially rewarding, but it also doesn't make you feel good in the work that you're doing with patients, because it seems like you're just fighting with insurance companies and on the line, on hold a lot. And if somebody doesn't leave practice, they end up reducing their FTE. They're working kind of patient-facing hours. And so it leads to people saying like, well, I have this primary care physician, I have the specialist, but they're never available. Why do they only work like 2 days a week? And it's because kind of that maybe all that is sustainable for them with all of the administrative burden that is associated with seeing patients for those days. Happy to answer more questions related to that. Thank you for asking that question, Representative. So in my organization, how we help to deal with those things, because I know it's such a big reason that clinicians leave. And of course, the healthcare system needs to have the clinicians available. So they're trying to keep us there. They have basically hired teams for each of these issues. So we have like a prior authorization team, we have a refills team, we have referrals team. I think there was a list earlier of all the different kinds of burden. There's basically a team hired for each of those things. There's a lot of turnover within those teams as well, because again, the work doesn't really make you feel good. It's just a lot of paper pushing. Some of that stuff, I agree with what Jed said earlier, like some of it is necessary and kind of makes sense. But a lot of it does not make sense and just adds to burden. So as far as prior authorization, some examples I can give, as a primary care physician, I prescribe a lot of different kinds of medications. We treat a lot of ADHD now in the community because there's a lack of mental health providers. So a lot of that has become a regular thing we manage in primary care, and often insurance formularies are changing what their preferred ADHD medications, and sometimes patients are changing insurers, and so then they have a different medication that is covered for them. One thing that we've always kind of fought for is if a patient is already on a medication, to not make it not available to them anymore, and to put a prior authorization kind of burden against them or have a declination against them to allow them to stay on something that is working for them. That is true in some areas, but not always. And so sometimes patients will be coming in regularly on a medication doing really well, and then they're like, oh, my insurance changed this formulary. Now this one's not covered. Apparently it costs $600 for me now. Like, what else can I do? And often we just end up kind of being like, okay, we'll try sending this one instead, see if it is one like affordable for you. And then after that, see if it actually works well for you, if you're having side effects with it. Once we have that information, we can kind of appeal it again, see if then it's covered or if they say other things. But especially with the ADHD medication shortages recently that you guys have probably heard about as well, it often means that we're trying multiple different medications, and all of that stuff doesn't really happen during a visit because there's not really anything to talk about during the visit except how they're not able to get their medication, but we're just sending different medications to the pharmacy, getting their responses back. Sometimes it's like, oh, you have to try these 5 different things, and actually 4 of those medications are not even available right now because of the shortage. It's a little bit of a nightmare, and it makes something that should be, you know, something we can help people with, because ADHD can be very disruptive in people's lives, and not being able to have their medication is very disruptive. But prior authorization adds to a lot of that. It means patients are calling into the office repeatedly trying to figure out those things. And, you know, we understand why they're calling all the time, but then we're calling the pharmacies all the time. They don't have staff really to deal with this right now either, because they're also short-staffed. And so it's just something that eats up so much time. And if there was, you know, even if it was a clear process, like these are the first tier, and if you can't do these ones, then we can do these ones, and that was routine across the board, that would be something we could work with a little bit more easily. But instead it changes insurance to insurance. And so it's not something there's like we can have a cheat sheet on. It's just kind of trial and error each time we need to make a change. Also true with psychiatric medications, not so much with the kind of most common, like kind of Prozac, Lexapro, those sorts of things are generally covered, but the things that are more expensive for insurance companies, often they're putting more barriers up on, and that can be treatments for bipolar and schizophrenia, conditions that are, you know, really not good if they're not under control, can be really disruptive for the patient and people around them. And often those medications will have the same issue where the insurance says like, oh, we're not covering this now, try this one instead. And the patient will say like, I tried that before, it didn't work for me. But they're like, oh, well, we need evidence. They need to try it again to make sure it didn't work for them, or make sure it caused them a side effect again. And then maybe we'll cover this other option. And that's really something that if there's a gap there in their treatment, it can lead to a hospitalization. It can be extremely destabilizing for people. I think a lot of the medications you might hear ads for on TV, medications for plaque psoriasis, rheumatoid arthritis, all those things, they're expensive. And so that's why there's a lot of marketing campaigns behind them. But what happens on the patient side is often those are not covered by insurance unless there's kind of multiple other things that they've tried, prior authorization processes that go through. And so as a primary care physician, those are usually medications that specialists manage. But part of the reason they have to be managed by specialists is because the prior authorization processes are so burdensome, they kind of have to be managed by a specialist office to actually get people the medications that they need. This is also an issue now with medications for weight loss, which can be very beneficial for people in helping to manage chronic conditions that can come from excess weight. Sometimes severe acid reflux, diabetes, high blood pressure can improve with medications for weight loss. But those have also experienced a lot of changes as far as what insurances will cover. Some insurances would cover Ozempic before, don't cover Ozempic anymore because there's too many people who are interested in it. And that's really a battle that we're fighting all the time, because patients will think that it's because primary care physicians are not wanting to help them. And it's not that. It may just be too burdensome to try to go through the prior authorization process for every single patient who potentially could benefit from those medications, because it is so convoluted and it may change from time to time. Oh, I see a message that I'm just going to read real quick. Oh, thank you, Jane. Another piece of administrative burden that it can be really challenging for patients who need durable medical equipment. So those are things like crutches, potentially wheelchairs, shower chairs for people who are unstable in the shower. Those are things that often are actually covered by insurance, but they work with different medical suppliers to provide those to patients, things like blood pressure cuffs as well. And many of these items, aside from, you know, motorized wheelchairs, many of them are not actually that expensive out of pocket, but they're things that insurance should cover. And sometimes patients, especially our patients who are lower income, are not actually able to afford out of pocket, even if it may only be $50 or something like that. The answer from insurance companies is that the patient should figure out which company that they work with and provide us that information. But often that's not practical for patients to wait on hold for an hour to get that sort of information and get it back to us. But we are also in our offices not equipped well to have to be able to wait on hold for an hour because we have calls coming in all the time as well. And so if there was kind of a simple process for that, that would also be helpful, because I have a number of patients where, you know, I have a prescription written for them to get this item that they need, and yet I don't have the information to have where to send it. And if we called insurance for every single one of those questions, we wouldn't have time to take care of a number of other issues that are coming into our offices all the time. Finally, I just wanted to share a story of a patient who recently has been impacted by these prior authorization issues. A patient of mine who came to me initially, she had transferred, she had moved here from another state and was just kind of needing to get everything back in place with her medications. She has inflammatory bowel disease, which can include Crohn's disease and ulcerative colitis. Her main issue is ulcerative colitis, and it's well managed with injectable medication that she was getting. And so we got her a referral in place to go to a new GI doctor in Washington, and they were to start her on the medication. And with her being on new insurance in the state with her new employer, they had to start going through this prior authorization process, even though she had been stable on this medication before. And so due to issues with getting her the prior authorization, she ended up off of the medication for multiple months. When she was able to restart it again, finally, when insurance finally approved it for her, even though it was you would say like good insurance, it was a good kind of private employer insurance. There was still that much delay, and she had been off of it for so long. She actually ended up having an allergic reaction to the medication that she had been stable on previously. So then they had to get her started on a different medication, and insurance denied that initially. First wanted more evidence that she needed it, and wanted her to repeat labs showing that she needed the medication and that the previous medication had worked, which we actually could not provide evidence of because she hadn't been on the medication for so long. And the only thing we could show with her labs is that everything was in terrible control because she hadn't been able to get her medication. The result of all of this at this point is that because she still hasn't been able to get the new medication, she's having to go on a medical leave because she can no longer work with the severity of her symptoms. And this is the consequence of all of these challenges that are put in place by these administrative issues. So again, I appreciate your attention to all of this, and I'm happy to answer questions after the rest of the panel goes. Thank you.
Thank you, Dr. Hong. I think our next panelist is Samuel Wilcoxon from Premera. If you could turn your camera on and unmute. Is he there, Marty?
Hey everyone, can you all hear me now?
Yes. Yes, thank you.
Awesome. Awesome. Let me just make sure. There we go. Came on camera. All right. Hey everyone. For those who don't know me, my name's Samuel. It has me tagged as Premera, but I think it might be more accurate to call me in this role as the statewide regulatory committee chair for the Association of Washington Health Plans. In my role at Premera, I'm a senior compliance and ethics program administrator. You may be thinking to yourself, why is compliance and ethics in this conversation or something, right? And the reason is because a lot of my work involves working with people like Jane Beyer with OIC to essentially work on the regulations as they're developed and to make sure that Premera is educated on it, right? Knows how to implement it. I come here by way of background of legislative background and the regulator background, right? So I worked as a legislative advisor for the Assistant Secretary of Health with HHS. And then before that, I was with Congressman Rick Larsen. So I say that as a background because you might notice that I don't always maybe talk as kind of technical or formal as some of the other insurance carrier types you might have met over the years. But I'm going to try my best to really bring both a plain language as well as some context to some of the topics we've talked about today, as well as administrative simplification. You know, what a buzzword, what a kind of loaded phrase, right? especially in a world where, again, like we heard, it could be framed as administrative burden on providers or administrative burden in general on everyone, right? I'll share my screen real quick if that's okay. And make sure I share the right screen. Okay. So y'all should be able to see my screen now. I'm gonna flash this quick slide. We sometimes show this slide internally. I put this together to almost put a little bit of fear of God in people sometimes whenever they're new to the insurance industry, right? And it's the idea that we're a very highly regulated industry. Premera operates in Alaska and Washington as well, like we mentioned, ERISA, federal level, right? I can only imagine the plans that are working in 7, 8 states, right? What this looks like for them, you know? Again, we could even probably update this to maybe shuffle around where how MedSup can work with both HCA and WABI, things like that, right? So it's one of those topics where it's always kind of a shifting regulatory environment, and it's one of complexity. I think that this is important to keep in mind when we talk about administrative burdens, overheads, and how to simplify it. Because like we've talked about today, and again, because I'm from a legislative and regulatory background, rules exist for a reason, and sometimes, and filings, regulatory requirements, some of the administrative requirements we have on our end as carriers, they exist for a reason. They exist to make sure that we're providing a standard or a good experience to consumers and members. I think that that's something that a lot of people would appreciate whenever they hear how insured carriers think about our compliance obligations, that they are an obligation we owe to our members. We think about this whenever we have to file our rates. Like was mentioned, I think Joan mentioned filing rate increases. You know, we saw double-digit increases, and I think Jane's office usually puts out an annual press release around these rate increases, right? Those rate increases reflect the increase in the costs of claims on our end. We are watched very, I mean, it's a very regulatory requirement to file those rates and to work with OIC during that process. As Jay mentioned, only proposed rates so far, right? Nothing's been final. So when we think about barriers to administrative simplification, I wanted to kind of bucket it into ways that I think carriers talk about it, right? At the top of the list here on our slide, we're going to have variations market to market, lines of business to lines of business. As y'all saw in the last slide, there's overlapping requirements. There's burdens that we have to navigate, including credentialing, network adequacy, rate filings, all of these things, and they oftentimes require us to ask information from providers. I think what's been talked about a lot is prior authorization, and I'll kind of touch on that later on the next slide. But I wanted to bring this up because this is one that comes up in terms right now in the discussions we have with the state about implementing the new prior authorization requirements. I would hop to the second one and say that cybersecurity and data privacy, we know the target is on our back right now. We know that after things like Change Healthcare, that the healthcare industry, we hold a lot of personal health information. We hold a lot of information in general about a lot of different people, including financial information, where they live, things like that. We have to navigate these obligations just as much as we have to navigate the efficiencies that are gained from data sharing or the efficiencies that are gained from leveraging new technology. I wish I could say there was a clear answer, but I think that if we ask the federal government, there's not always a clear answer in that area. I think back to the conversations that the Office of National Coordinator had during the pandemic, also around these topics of wanting to both protect our healthcare data as we provide public health monitoring, but then also provide this insight and this transparency into this population health concern, right? I don't think that's going to go away. Knowledge gaps as workforce develops and technology accelerates. This is one of my favorite because this is one of those times where I can just be bashful and admit to everyone I'm not a computer genius. I have degrees in philosophy and law. I am good at government regulations, things like that, right? But when we talk about prior authorization, building out APIs, I have to immediately step into the world of a computer programmer, a developer, someone who understands very technical implementation guidance. And again, I wish I was part computer or something, but I'm only human in that area, right? So I can only do the best I can to facilitate policy conversations with the OIC on that topic, right? All of our carriers are facing that. All of our carriers would love to be able to hire tomorrow someone who's an expert on the prior authorization rule that was released this year and knows exactly what our businesses need to do to implement and to comply, right? Those expertise don't exist whenever we're talking about new and cutting edges of healthcare. Those expertise are gained through hard-fought learning and through an investment of time really on our full-time employees' part. What I heard today was that providers also have to make that investment. I think I would go to the next one and say that shifting regulatory requirements, it's more of a reflection of what's happened at the federal level. We can take Section 1557, for example. We had the Trump administration issue a Section 1557 rule. We saw that go through the grinder of a court system. We saw it come out on the other side, and we were left as insurance carriers in the nation saying, do we implement this? Or do we have to implement this? Do we have to implement everything that wasn't vacated? We had an election soon after. The Biden administration withdrew it completely and issued a notice of proposed rulemaking on their end. That helped clarify and provide guidance. I would say that these shifting regulatory requirements oftentimes can make it difficult for us to identify areas that can be changed because it is inefficient. I'll actually pause here, I guess, and see if there's any questions about any of those points that I just covered. If not, then I can dive into prior authorization. Okay, so prior authorization, interoperability, really. That's the interoperability piece is what I really would focus on for this conversation. That's the big administrative simplification that carriers, we see a benefit. It's the definition of a strategic payer provider platform, right? If we can really get these APIs up and going that are required by these federal laws and even the HB 1357 law, and we know providers are going to actually use them, that's a win, right? We also are spending a lot of time responding to providers saying, hey, actually, if you look at the payment terms that we clarified when we contracted with you, this isn't an appropriate claim. We need to have our claims filed appropriately in our format because oftentimes we're subject to audits at different levels. It creates a cleaner compliance environment for things to be done standardized. I would say that when I look at the table down below, I have to admit that I tend to be a bit of a pessimist, right? So I wanted to make sure to capture that there's a worst case or a best case scenario whenever I see these kind of huge prior authorization interoperability rules going forward. At its worst, what it could end up with is patchwork interoperability, right? You have to work with an Aetna system or Cigna system, and then the Blues plans have a system, right? It sounds like we've just recreated the same manual hurdles that these providers have shared their issues with today. Sounds like we're creating the same inefficiencies that y'all have identified in y'all's work groups and prior meetings. Now, whenever we can make sure that states stay aligned and lockstep in terms of the technical guidance with the federal government, what I mean by this is the things like the technical implementation guides that can be released without a federal notice of proposed rulemaking. They can just be released with an update of a website. If those can stay aligned in lockstep with the state, carriers see a benefit. Carriers see interoperability as an outcome to us making these front-end investments. I mentioned front-end investments. That gets to the next point. Front-end investments without a guarantee of provider adoption. when I think about this, I think about all of the hard work that went in on the federal level to think about a provider directory and how that should be implemented from a regulatory perspective. How the value was all for the consumer to be able to know who was in network. And I think now about how often providers aren't responding to the plans when they reach out to them to ask them, are you still going to be listed as an available provider taking new patients? You are contracted in our network. Are you still accepting new patients? When we don't get our response, even though we're legally required to reach out to them every so often, I believe it's a 90-day time period. You know, that's just us not getting a response, right? That's not us being able to knock down a door in Island County at a doctor's and say, are you accepting new patients? Tell us. That's not how the law works. If we don't get providers to buy into some of these APIs, these interoperability requirements, then ultimately to the carriers, there's little utility, right? We see the biggest goal from the conversation y'all are having, really helping us to facilitate provider buy-in for these simplification investments. Again, we've talked about all the money in the healthcare industry today and how it gets spent on administrative inefficiencies, right? It sounds like, I think Rep. Joe Schmick said it well, we all have a vested interest in addressing those. So if we could lower how much we're having that passed on, or we're seeing that come through in claims, because we are being told by providers that they need to account for it when they contract with us. We're being told that by large conglomerated and consolidated healthcare systems. And we don't understand, right? Because we feel like they would have the resources to help address internal administrative inefficiencies. But the plans are the ones that are left with network adequacy requirements. So we see it as, I think Jeb described it as multiple doors. We only see a few doors in certain counties. We only see 2 doors for people who are willing to contract with us, right? In those situations, I wish we could say that we could define their administrative steps, but a lot of times, again, I think there's maybe a difference in opinion of who necessarily has all the negotiation powers when we go to a healthcare system, right? Again, provider adoption is something that we hope that y'all can help us with, because if they do adopt these interoperability investments that y'all have outlined, then we really do see a benefit for all Washingtonians. That's kind of my spiel. Again, happy to answer some questions though.
Representative Schmick?
Yeah, I was curious with the consolidation of providers that we're seeing throughout the landscape. When they align with a bigger system, are you finding more operability and they have the IT horsepower, so to speak, to be able to comply better with being able to enter the data on the proper form to make it easier for you? Or is it still a problem even when they're aligning with bigger systems?
Yeah, so I think I can answer that in terms of how we reprocess claims, right? Or claim reprocessing, right? Because we don't get to see it on the side of the hospital, how much resources they're putting into it or how it works on their end, right? We get to see, no, we still have to reprocess claims for the big hospital systems too. You know, it doesn't go away. The mistakes are there. They're human mistakes. Part of this is leveraging new technologies. Part of this is also acknowledging that, you know, whenever you have a form that needs to be filled out by someone who's very tired and has done a lot of work, whether they're from a health plan or a hospital, mistakes can happen. We try to minimize those mistakes by standardizing things whenever possible internally at Premera. So I think like at one point in time, an ERISA problem was presented, right? I wish we could say that we saw this huge benefit to running all of our ERISA claims one way and having a whole separate system for that, right? But the fact is that would require us to operate a whole like third, and we'd have to create an almost ghost insurance company to handle all these claims a certain way in this way, right? So what we do is at least in Premera, we look for alignment across lines of business and market to market. Yeah. Hopefully that kind of gives you perspective on how a carrier would answer that.
All right. Thank you, Samuel. And
Thank you.
yeah, and there might be questions at the end, so I'm hoping you're sticking around. Our fourth panelist is Steve Woolworth from Evergreen Treatment Services. And there he is. Hello, thanks for joining us.
Hey, nice to be with you all today. My name is Steve Woolworth. I'm the CEO of Evergreen Treatment Services. We are in our 51st year. We are a community-based behavioral health organization. We operate in about 9 locations, primarily in King County, but also in Thurston and in Mason. Last year, we served over 12,000 people, and we have around 350 employees. We have sort of 2 arms to the organization as it relates to care. One is opioid treatment programs, which we've been operating since 1973. The other is really street-based social services, primarily serving people living unsheltered with severe behavioral health conditions. Our revenue is about $45 million a year. Our overhead rate is about 17%. I just give you that for the context in which we work. I've been listening to this conversation and trying to think about what I was going to say that might add some value. Certainly a lot of what's been said has resonated with me. I think that there are a lot of, we operate, I would say, as sort of a niche organization within behavioral health. And in some ways, behavioral health to me has seemed overly regulated to the point of it's really challenging. And we operate under some fairly archaic regulations that go all the way up to the Drug Enforcement Agency because we dispense a Schedule II controlled substance. But no doubt, as it relates to the financial transactions ecosystem, there's a lot of opportunity for simplification. The technology infrastructure, lots, one EHR would be really helpful. The workforce shortage that we're experiencing actually creates a lot of administrative burden. So I'm just highlighting those areas. But one thing I think and I'm not going to talk too long here because I know it's a big panel, but one story I want to just sort of highlight. It seems to me that any regulations or any administrative complexity that cuts across levels of government or different agencies within government provides a certain kind of punishment to providers. And let me give you a story because there are really real consequences to this story. And this is sort of an exceptional example, so it's not something that's necessarily going to be generalized across the healthcare system, but it just highlights something, which I'm going to talk about mobile medication units and mobile methadone units. Methadone is, in the treatment of opioid use disorder, it's long considered the gold standard that it can reduce overdose up to 50%. Okay, we were the 3rd provider in the United States to move out with mobile methadone dispensing in 1998, following provider in Baltimore and Boston who moved out in 1990. Okay, so we've been doing this a long time. We are long sought out as a thought leader, both within this state and across the country on how to do this work. When the pandemic arrived, we parked our unit for open air dosing. Okay, so our mobile methadone unit did not, got pulled back from going out into the community. We had it in the parking lot for those who were symptomatic at the beginning of the pandemic. Okay, we had it there for several years. The DEA changed their licensing requirements in August of 2021 and put out these new requirements, which the idea was to incentivize, right? Because we've been in a presidential emergency for drug overdoses in our country since 2017. So finally, in 2021, the DEA changes their licensing landscapes to incentivize the purchasing and essentially launching of mobile medication units to take medication to where people are, which is out on the street, right? People who are living unsheltered are at high risk for overdose, okay? Also taking it into correctional facilities, often through mobile medication units, where we also know there's a very high risk for overdose upon release back into the community. So here in Washington State, it took us 19 months to get approval to re-release our mobile medication unit as it related to the coordination between the Drug Enforcement Agency, the Department of Health, the Pharmacy Quality Accreditation Commission within DOH and onwards. Okay, it took 19 months for a unit that had been, for an organization that had been doing the work for decades, and for a unit that had already been out, right? Because nobody knew what to do with it. It was not a new unit, it was a pre-existing unit, and nobody knew what to do with it. In the course of that 19 months, there were no other providers who were delivering mobile medication and methadone to the downtown core of Seattle. In that 19 months, hundreds and hundreds and hundreds and hundreds of people died because government couldn't get out of their own way to figure out how to re-release a unit that had already been serving the community for decades. So in terms of simplification, I just use that as a story because there's been a lot of talk about the back end, the bureaucratic, the financial piece, the authorizations, the claims reprocessing and all of that. But I just wanted to make it really real as to the level at where lives are lived. And for providers who were literally on the front lines of this public health emergency that continues to worsen, it takes a long time for help to get to the front lines. And so I just wanted to use that example as just one. We released a white paper. We have sent it to the DEA. We sent it to Governor Inslee. We've sent it to elected officials. We've sent it to the Healthcare Authority. We sent it to the Department of Health. We sent it to the Pharmacy Quality Assurance Commission, highlighting all of it, all of our communications, pushing. And that's how long it took, 19 months since we first started, 19 months. That's my story. Thank you for this.
Thank you for sharing that. So I just want to open it up for questions for our four panelists. Do you have any questions? Representative Schmick.
Steve, when you first started talking, you talked about behavioral health being over-regulated. Could you expound on that a bit so we just can understand better, please?
Well, our clinicians, we spend a lot of time doing documentation, right? Our substance use disorder professionals, our medical providers, and I certainly understand the need to document the care we provide, ensure that we are billing for what we actually do, and that need for that accountability. So by no means want to minimize that, but sometimes the level of documentation that's required and the amount of time, and we were looking at productivity of our clinicians, how much time is spent patient facing versus how much time is doing back-end documentation around the care. It just feels like that ratio is sometimes out of balance, and sometimes it's less a system thing and it can be a personnel thing in terms of the the training, the knowledge, the prior experiences of some of those in care positions. Our requirements for substance use disorder professionals are a lot less than they are for mental health therapists, for example. There are some challenges around with some folks around skill levels, navigating the computer environment, navigating the requirements of documentation, but those of us in behavioral health talk often about it. It feels like sometimes the emphasis points are in the wrong place.
Go ahead, Representative Schmick.
Thank you for your indulgence. Do you find this in all silos? Medicaid, Medicare, private insurance, or is it more egregious in one area than others?
Well, because we're a real specialty provider, I think that's a question probably best delivered to a more comprehensive behavioral health provider who's providing both mental health and substance use disorder. In some of the committees that I sit on, with some of my colleagues, that's where I hear that coming from more. That's I come from that prior world as well. It's a lot of documentation. I'll just say that.
Can I follow up on that one? So Steve, in terms of documentation, is it documentation for care authorizations? Like
It
for
can-
prior auth and
It
concurrent
can be.
review?
It can be. Back when I was doing inpatient residential treatment, that was a huge struggle. There's a lot of time consumption on that, and then also continually needing to justify medical necessity for ongoing reauths. It was absorbing a lot of time.
Yeah, I mean, one of the things that Senate Bill 6228, which is the bill that directs us to do this uniform process, it says that an initial authorization can't be any less than 14 days, and any concurrent review for residential treatment can't be any less than 7 days. So that was the legislature stepping in around the issues around frequent concurrent review and little chops of 2 and 3 days. So yeah, that was, I mean, I'd like to ask all the panelists if there were, what would your like top 2 priorities be for where you start admin simp? Is it credentialing? Is it prior auth? Is it just what would the top 2 be from each of your perspectives?
We can go in order.
I'd be happy to start.
Okay.
I had noted earlier that when we do our surveys of our members, they say prior authorization is their number one sort of administrative headache. The other area where we've seen trouble over the last few years is licensure delays. That can really gum up the works. You can't bring new physicians and other providers on the care team, then that spreads everyone else out very thinly, including the administrative burden that must take place. So those are the 2, Jane, that I would call out. And I should note, I should give a shout out to the medical commission, who has drastically improved their licensure turnaround times over the last few years. So shout out to them.
Thanks.
Dr. Huang, do you?
Yeah, I would say prior authorization would be number 1 for me too. Number 2 right now for kind of challenges we're dealing with is probably communication between medical clinics and pharmacies. I'm not sure that that's something that you guys can fix, because I think a lot of it is just that there's short staffing in the pharmacies right now, and that is providing challenge for them being able to answer their phones. There's a lot of pharmacies we work with where they just don't answer their phones anymore, and the only way to kind of communicate with them is to have a patient go there and try to get information. So yeah, I think those 2 things are probably what take the most of our time.
Thank you. Samuel?
Yeah, I mean, just to be honest, like, as prior authorization keeps coming up, it seems like the states acted in one way for prior authorization, and then the federal government has their big rule on prior authorization and the APIs around it. We're getting one from Alaska. We're getting a lot of them from state to state. I think that what I would stress to everyone is that are we really creating an interoperable system if we're creating a bunch of different interoperability standards, right? It seems like one of those things where the market to market considerations need to be considered. I think that in some ways, at least this is Primera's perspective. So take off the AWIP hat, put that on, you know, to say that Primera's perspective is we appreciate that Washington Accent was a leader in this, right? It makes it to where, again, as far as turnaround times or something like prior authorization, we try and standardize what we do in Washington to Alaska as much as we can, right? That creates an efficiency for us. We save on the overhead. That's just the honesty, right? Whenever we look at another problem, it's provider buy-in, right? So I think that, like we acknowledged a bunch of times, we understand that if you've been a provider and you've been practicing for 25 years, you've probably had every different insurance carrier that's ever operated in Washington State come into your office and say, here's how to communicate with us. We're going to get rid of all the inefficiencies you've ever had. It's going to be such a clean process to work with us. We're so different than every other carrier, right? That's probably happened so many times to a primary care physician in our state that's been here for his entire career, right? So my thing is there's a reluctance sometimes from that provider in that small town to buy into a whole new technology, or for these BH agencies to make this huge front end investment on all this data sharing stuff, right? Because a benefit is there necessarily for, right? So the provider buy-in and kind of helping that along is a huge one. That's kind of the top of the list for us, is those. Yeah.
Thank you. And how about Steve?
For us, it's less about prior authorizations. That's not a pain point for us, actually. We fight with payers all the time. So on the claims processing, that is an area where we have a lot of folks working on the back end, fighting with our payers and getting timely payments and all of that. And secondly, I would say, you know, the data sharing, particularly as it relates to emergency department utilization and follow-up with emergency departments, and we want to talk about cost containment and things like that. That is where I think we just I think the system's struggling, and we're all sort of really struggling to do better there.
Can I ask a follow-up question? What about, so lots of discussion about shifting to value-based payment with quality standards built in. Maybe for, especially for Diana and Jeb, how much do you hear from providers about different quality standards or performance standards being associated with different health plans or different value-based payment methods?
It's a good question. A lot of these conversations happen at the practice and insurer level, and like we're not privy to those conversations. But what I can say, speaking with physicians in private practice, is they might have a hesitancy to adopt more value-based payments because they're just overwhelmed, and it's hard to stop everything and implement a new payment model. It decreases your efficiency and sort of it can be challenging, like everything is for smaller practices, less resources. Speaking to physicians at larger health systems, they don't even check the boxes. They just provide the care, and there's whole teams behind the scenes that make sure that you're doing the right things in order to sort of maximize performance under value-based payment. It's something that the Medical Association has struggled with to sort of find like how we support our members. But again, a lot of these details are worked out between, you know, in these contractual arrangements we don't have a lot of insight into. Yeah, that's what I'd say there.
Thanks.
Yeah, those things. So I would say that the majority of clinicians probably are not paying that much attention in the large systems because of what Jed said. I sit on a quality committee within Swedish, and we talk a lot about it, about kind of new things that are coming from the payers, because they are quality metrics, but they're tied to payment as well. And so trying to figure out ways that we can meet those metrics, but because a lot of them add burden, it is kind of a challenging topic. So like with Medicare, there are these HCC diagnoses that are tracked. And so whenever we're seeing a Medicare patient, that is kind of the priority within our system right now, to make sure that if they have an HCC diagnosis, so these are usually kind of higher risk diagnoses like diabetes, heart disease, heart failure. There's and a number of mental health conditions as well have this HCC that is attached to them. In the electronic health record that we use, Epic, which has the MyChart as kind of patient-facing portal and is kind of the most commonly used electronic health record right now. Like the HCC codes are like kind of highlighted, and there's some things that are built in where it'll kind of pop them and say like, hey, you haven't documented this HCC code yet this year, like make sure you document that. And so there's these things that pop up. But I mean, from the clinician side, is kind of annoying because you'll want to just see this patient and kind of document something quickly. And then it's like, well, you need to check in all these things, even though this isn't what the patient's for today. Like if you check this off, then we can show on your kind of productivity report that you have documented these things already this year. And so now you don't have to worry about it. And there might be some payment kind of related to that as well, like my current compensation model, even though part of it is kind of based on my kind of full-time status or my part-time status. The other part is kind of based on certain metrics that kind of change every year. So one part is based on how much of the HCC stuff that I'm capturing and keeping that up to date. And even though that documentation is not like too much, it's just the fact that you always have to kind of be checking these boxes related to it that can be kind of frustrating. And then the other piece of it is kind of cancer screening metrics. So right now, this year, it is that we have to have a certain number of patients who are documented up to date with their colon cancer screening and with their, what's the other cancer? It used to be cervical cancer screening, but this year it is, breast cancer screening is the other one. And then also making sure that their diabetes is under control based on their average blood sugar. Those are kind of 3 metrics right now. I think because there's so many things to pay attention to all the time and it's always changing, we just kind of get these emails. They're like, okay, this year, like make sure you're focusing on this. The thing that is coming down now is that some of the payers are requiring that patients are seen within a certain amount of time of being seen in the emergency room or in the hospital. And I think theoretically, there's a benefit to that, to make sure sometimes things get missed between kind of hospital discharge, but it's been implemented in a way that if somebody went to the emergency room for kind of a broken bone, there might be a metric that they need to see a physician with, or they need to see a provider within the next week of that to get this certain quality metric. And it may be that that doesn't actually make sense, that they, have a treatment and they don't need anything done for it for another few weeks, or they're going to see a specialist later and it's not actually something that primary care needs to be involved in. But we actually have this team now that for the payers that have that as quality metric, they will see the patient and the patient might not know why they need to be seen because they've already kind of gotten their issue addressed, but they'll see them for a virtual visit just to be able to mark that box with the insurance saying like, oh yeah, we followed up with the patient within a week of their leaving the emergency room. So I think sometimes it leads us to have to do additional things because there's not actually space in our primary care practices to do all of those things. So there's this kind of hired external person. As a primary care physician, it's a little bit frustrating because we know that a lot of the cost savings from primary care is being able to have longitudinal care and being able to see our own patients regularly. But whenever we have these kind of additional things, it might be that it actually would be that I got a notice from the emergency room saying like, hey, I saw the patient. And if I actually need to see that patient, I would call them in. But instead we're like, oh, there's not room to see the patient who actually needs to be seen after the emergency room, but this one payer says that you have to see this patient, so we put them on your schedule, even if there's not actually anything to talk about. So I wish that we could kind of trust primary care physicians more to be able to do the relevant follow-up for their patients, but right now the system is so fragmented because of these different challenges that exist. Of course, primary care is overburdened, specialist care is overburdened, and then there's all this virtual care that is popping up to say like, hey, we can prescribe you a treatment for your hair loss, and you can just pay a fee for that. And a lot of patients, I think, are frustrated by all of it and saying like, well, if I can pay $100 for this right now and I don't have to deal with insurance, then I'd rather just do that. I think simplifying our access to care overall would be really helpful, and there wouldn't be patients and physicians who are kind of leaving the insurance model to be able to just kind of cut out a lot of this frustration.
If I may, just add in terms of value-based payment from a policy perspective, Medicare really led the way on a lot of this work through MACRA and MIPS. That was implemented 10 years ago. We've learned a lot about value-based payment in that time. I learned this morning that 80% of physicians that participated in Medicare were able to avoid penalty under MIPS this year or in 2023. But that 20% that were penalized were overwhelmingly small, underserved rural areas who don't have the teams to do this.
Yeah, good.
Thank you for sharing that. Samuel, I do see you've had your hand up for a while, so thank you.
Oh, yeah, it's really small. I was just going to say, Jane, we see people every time we roll out one of these programs, we see people, providers sign up for it. We never really see the same number complete it, right? It's like a retention issue we see with our quality programs, quality improvement programs, right? Where we're asking sometimes providers who are enrolling it at the front end, like, what can we do to help you get through this? And it does require documentation. Our perspective on that one is, again, like, and Jeb, like, you're probably in conversations like this too. I imagine we all are, but what is a high value benefit, and point to it, right? And what makes it high value for that specific population, that specific plan, that specific patient, right? What is that value, and how do we compare that? Well, some of the metrics that you're talking about, Diana, that we asked to collect, it goes back to us trying to build out a case to say, like, yeah, monitoring blood pressure, checking for some of these chronic issues, these are high value, these are sincere population concerns. And the sooner we catch some of these issues, the more we can all avoid a higher crisis of care for that patient that leads to a big medical bill on all of our ends, right? So that is one of the reasons we require that paperwork, that paper pushing,
I don't know if this is a question or comment, but I work in the Indian healthcare delivery system, and we have community health representatives and community health nurses, which probably maybe a little bit like a cross between a medical assistant and a community health worker. And we utilize them for the follow-up care. So a community health rep or a community health nurse can actually go to somebody's house and check in on them after they've had an ER visit or been released from the hospital. Is there a value in the system to that kind of worker? We have trouble getting reimbursed for that. So that's, funding that comes from a different place, but, and then they have a direct connection to the primary care provider for that person. So if they're at the house, they can call the clinic and say, oh, they've got these 2 prescriptions that, they were supposed to put one of them. What is it? Or those kinds of things. And they can even use a VPN and access EHRs. I think, and I agree, Dr. Wong, that we need to trust doctors more than we do, I think. Sorry, that wasn't really a question, but thank you to our panelists. We really appreciate, we've had other parts of the system talking about this. You guys are right on the front lines. And so it's really helpful to also hear from you about what is painful in our current system and what are the things we can really continue to work on. So thank you for your time and coming here today and sharing with us.
Thanks for having us.
Yeah, thank you.
Yeah, thank you for having us. I did want to say, Vicki, I do think there is a lot of value to having people come out to the home for a follow-up. I think that's a wonderful service and it should be compensated. I think there's often these programs that exist that don't have good communication with the primary care physician, and that's where they can be lacking, where there's stuff that's happening and we're not aware of, and it fragments things further. But as long as it's something where it's connected to the person's existing healthcare team, I think that is really valuable and should be supported. Thank you so much for your time. I will.
Thank you. And thank you for your time, because you know, you're a provider, so we really appreciate how much effort it takes for you to leave work and come and do something like this. So thank you.
Thank you all for your work.
All right, so next, I think Liz is going to take us through a discussion on our next steps.
Yeah, I think if we could just pull up the slides, that was just, so really, I appreciate all of those folks and talking about, you know, why we're doing this work and some ideas about what this commission might be able to focus on. So appreciate all of you for asking questions and asking for recommendations from them. So that's really helpful, Jane. I think what we're really trying to drive towards for all of you is coming up with some potential areas for making some recommendations. And I don't know if we're ready to ask that particular question, or if we want to just focus. If I asked you right now, what are some areas that you heard about today or in the last couple months that you would like to spend a little more time on or focus your recommendations on, and what do you need from staff and this consultant team to help you understand more about what that might look like? Bidisha.
Yeah, so actually, one of the things I would really like to understand is, you know, whether it's simplification with respect to prior authorization or some of the other things people have mentioned. I would like to understand how that impacts different payer types. Because one of the things Jeb mentioned, and that was his last slide, was the unintended consequences. And they just talked about value-based payments. And it sounded like that rural areas actually could be having some negative impact of something that is actually, you know, theoretically a great thing, that patients should get quality care, but in practice, it might have unintended consequences for certain populations, especially disadvantaged populations, maybe Medicaid covered. And I would like to have an understanding of that, what a simplification is. If we just take, say, two things, prior authorization and claims processing, what does that mean in terms of adding costs across payers or reducing costs across payers? So that would be something I would really like to dive deep into.
That's great. Appreciate that. That's really helpful. Nicole.
So if I'm thinking about it from like a patient perspective and something that can potentially immediately help patients, I think that communication between the pharmacy and the medical clinics might be an interesting area to explore, since it seems like that's also just a kind of an ongoing problem. And if there's something that we can do in the short term to help address that issue, that would be lovely, at least from my viewpoint.
I'm just taking notes. Thank you. Others? I know we heard from Jane and Representative Schmick. How about you, Charles? Any thoughts? I know DOH has there's a big piece of this stuff that you do, so.
Yeah, no, I'm more on so I know with administrative simplification, there's kind of two ways to look at it with regards to the incremental efforts and what can be done now to improve the system. And, you know, the general theme, I think, from the presentations has been that there are increments and improvements that can be made, but we shouldn't expect significant cost savings from those. And I think that goes back to one of the earlier comments by someone who kind of pointed out, as long as you have multiple players and the system that we have today, there's really, you can't, there are efficiencies and things that we can improve, but I don't think you can expect to have significant savings from that. So personally, I'm more interested in seeing how, with regards to the modeling of how different the future design of a system, how different things will be in regards to savings that could be realized from simplicity versus the system that we have today. But I don't have any additional suggestions or questions about the incremental opportunities at the moment.
Joan, Representative Riccelli. Dave, any other comments? Vicky?
I was waiting for anybody else to speak. But, one of the things that I heard clearly and that I know we deal with again in the Indian healthcare delivery system is that stigma related to behavioral health and especially substance use disorder that really drives the overregulation and over-reporting. I think, unfortunately, a lot of that happens at the federal level. So we've done a good job in Washington State of trying to clean that up. I know Jane has done a lot of work with the OIC and trying to make sure that there's parity for, the private insurance payers for behavioral health services. But it just strikes me that what the gentleman from Evergreen shared is still such a problem, that these, people are dying because they're not able to get care. I mean, they're dying from bureaucracy. So, I just really think that's important, but I kind of wonder what we can do at the state level to address some of the issues that are coming from SAMHSA and just the federal laws.
All right, I see that my call out has now resulted in some hands up. So yes, and Vicky, Steve's example that's so tragic and awful, and we need to do better. So Dave.
Yes, I apologize. I told Mandy earlier, and if I got called out, that I had to step out for a
No problem.
legal meeting for a period, and everybody got my hand up, got me back into panelist. So one of the areas, so I got about 2/3 of the panel in, so I have no idea if this actually came up or not, but something that I was hearing, especially from the second panelist, is some of the, I think about the lack of uniformity in formularies for drugs, and that drives a lot of bureaucracy. And some of that is different entities or insurers trying to chase different rebates and who gets the best deal this day. And but it boils down to formulary differences. And there's structural reasons why, like I said, why different formularies exist for different plans, but that just creates well, you got to try this drug. If you're on plan A, you've got to try drug 1 before you can have drug 2. And if you're on plan B, then you can have to try drug 2 before you're on drug 1. And I was really kind of, I'm not bemoaning the point that came up of sometimes people having to try drugs that they've already tried or prove in their medical records what they were allergic to or not allergic to. And that breaks my heart when I hear that. I can't sit here and say for sure that never happens in any of the PEB plans, but I know when we do transitions, we talk about legacying people over, making sure they don't have to redo step therapies, things like that. And I know there's not uniformity across the insurance community on that point. So I think that there's a lot of consumer bureaucracy that happens when it comes to formularies differences and step therapies and lack of uniformity in the system from that. And so that's a really tough nut to crack, but I think it is part of the administrative simplification arena.
Joan.
Yeah, thanks. Dave, my call out response was slightly similar, but even more macro, which is I found myself as we were listening through the panelists trying to gauge for all the concerns that were being noted, where a universal health system would help solve a problem versus where it would exacerbate a problem versus where it would make no difference because of other health system challenges, Vicky, like stigma or shame, where that's how I was trying to orient, and I help connecting those dots for me would be appreciated, because that's an area where, of all the concerns we heard, or Jane, all the debates you've heard as the prior auth legislation has moved through, it's like, where does a universal coverage solution help with, you know, provider adoption and consolidation of a formulary. And, you know, I can, from a policy perspective and an operational perspective, I can mostly get myself there, but then other things that were being raised, I don't know that a universal coverage would address. So I just, to me, sort of delineating the bounds there of where we think the decision is going to be that's specifically related to having a more uniform delivery system. That's where I was getting a little, it was kind of reaching the bounds of what I felt like I could digest.
Jane?
So when I was listening to Dr. Huang's case about the woman who had ulcerative colitis, there is, and I don't know whether her health plan was regulated by OIC or not, but there actually was a law that was passed in 2019 to create an exception process for prescription drugs that goes around the prior auth process that says, if I'm successfully on a med and I can request an exception to get continued coverage. And whenever we talk to doctors about it, or whenever we talk to consumers about it, it is not well known. So I know OIC is thinking about what we can do to increase knowledge about it, but then the question becomes, is it just passing the law, or is it also sort of like systematizing the way it's implemented? So that it's not like one payer does it this way and another payer does it that way and another payer does it a different way. So that I think is, it's a good learning example for us to think about, and whether there's a way to make it more effective so that it actually accomplishes its purpose.
Okay. Well, great. I realize we only have about 3 minutes left. Appreciate everybody's engagement and conversation and points, and just going back and forth on this whole topic, because it is a really complicated area. And I think that there's some coalescence around a couple of things that we can take as a staff and come back and bring to you with more detail and information so that we can really try to make a recommendation in our 2024 report around this, because as we heard from our panelists, there are real implications that are happening. And I think, Joan, to your point, there are, you know, the universal system that we're all designing, there are some things that we know that this will fix, but what can we do in the meantime? And I think pulling forward, you know, from the work that OIC and HCA are starting to do, and other ongoing efforts at DOH, we may have some things that we can really endorse and try to, you know, put some rocket fuel behind. So appreciate that. And I'll turn it back to you, Vicki.
Thank you, Liz. I guess it's just time to close the meeting. So thank you all for, you know, I know this 3-hour meeting's a little bit harder, and appreciate all your time. The recording and summary of this meeting will be posted shortly on the Universal Health Commission page on the Healthcare Authority website. Want to thank our presenters and our panelists today. Really rich conversation. Thank all of you for participating in the conversation too. That makes for such a great meeting and is really helpful as we move forward in our work. Our next commission meeting is on August 8th at 2 p.m. And as a reminder, the meeting is 3 hours long, so we'll start at 2 and end at 5. And I look forward to seeing you then. I hope you enjoy some relaxing time this summer, and maybe we'll be a little tanner or more relaxed looking when we see each other in August. Maybe not. I'll be coming back from vacation, so I hope to be tanned and relaxed. Thank you. Have a great evening.
Good night, everyone.